Yes, ma'am, you can start now.
Very good evening to all my dear friends and colleagues who have joined us today, this evening. And we are very happy to have a grand webinar dedicated to very distinct and unique subspecialty of critical care, that is obstetric critical care. Now, for ages together, there have been challenges which have been very unique to this specialty, and especially when these patients, pregnant patients, become critically ill, come to intensive care unit, they pose their unique kind of challenges. Now, as we have been passing through this COVID pandemic and have been struggling with it for more than 1.5 years now, if you recollect or recapitulate our experiences in the first wave, when the explosions of this COVID-19 cases across the world, people were actually at the wit's end to understand how to manage COVID-19 moderate and severely ill patients, let alone patients who are pregnant and affected with COVID-19 illnesses. And there have been a lot of controversies and speculations about different kinds of management interventions and drugs which can be utilized in this patient population of patients, especially after they were admitted to the intensive care unit. Now, in this context, we thought it is very important to discuss and recapitulate and review our experiences and knowledge that we have gathered so far regarding management of obstetrically ill, critically ill patients. So we are extremely fortunate and blessed today have a galaxy of speakers from across the world and the best from our nation. And we'll have a series of talks starting from basics to specific situations where these obstetric patients fall in with the COVID-19 illnesses. So welcome you all again to this today's webinar. And I'm happy to welcome all the eminent faculties from across the world. We'll get to know them more detail as the session progresses. So the first session, I would like to welcome the chairpersons, Dr. Professor Pradeep Bhattacharya. He is a renowned intensivist of India and is currently the Chancellor of Indian College of Critical Care Medicines and Head and Director of Department of Critical Care Medicine of Ranchi, RIMS Medical College in Ranchi. And along with him, we have Dr. Sameer Sahu. He is a renowned intensivist of Odisha and is currently the HOD and Director of Critical Care Medicine at Amri Hospital, Bhubaneswar. So welcome Dr. Pradeep and Dr. Sameer Sahu. And I'm extremely delighted to invite Dr. Asit Hegde, who needs no introduction. And he's been an academician and critical care physician at excellence, at Par Excellence. And he's today here with us to talk about physiological changes in pregnancy and COVID-19. Over to you, sir. Dr.
Thank you, Actually, I'll be restricting my talk to physiological changes in pregnancy, not necessarily COVID, but all pregnancies. I think the rest of the conference will be on COVID. So whenever we talk about intensive care, we obviously, first thing we talk about is always the ABC. So here also I'll talk about the ABC. First, of course, we talk about the airway. So it's been known that failed intubation is 8 times more common in pregnancy as compared to the non-pregnant patient. And probably in every pregnant patient, the Malampati class, which indicates a degree of, all of you know that the difficulty in intubation moves up at least 1 grade in almost every pregnant patient. Therefore, when you're intubating the pregnant patient, we need to plan for a potentially difficult airway. And because of the increase in the breast size and the general weight gain, a long handle laryngoscope may not be work. You may need to have a short handle laryngoscope. Because of nasal congestion and nasal polyps, there's an increased incidence of epistaxis. So better to avoid nasal airways and nasal intubation. Also, because of edema in the airways, there is the narrowing of the upper airways in the 3rd trimester. So you might have to do with a narrower endotracheal tube, a smaller size endotracheal tube. Because of the increased progesterone levels, there's a decrease in the lower esophageal pressure. There's elevation of the intragastric pressure because of the pressure of the gravid uterus. There's delayed gastric emptying. All of them, of course, increase the risk of aspiration during intubation. Therefore, you need to take these precautions. Also, in pregnancy, a decrease in the functional residual capacity, an increase in the basal metabolic rate. Therefore, pregnant women tolerate hypoxia much lesser than the non-pregnant person. Therefore, the the tolerance of hypoxia is very, very short, and you need to obviously oxygenate them, and you can't afford a delayed intubation. Therefore, when you're intubating these patients, oxygenation is the highest priority by whatever means possible. Then you think of intubation, but always make sure the oxygenation is maintained because they don't tolerate hypoxia at all. In fact, even the All India Difficult Airway Association 2016 guidelines clearly mentioned this, that pre-oxygenation is mandatory. You give at least close of 10 liters a minute for 3 to 5 minutes before using a well-fitting mask. And even when intubating, you should administer at least through a nasal cannula, administer oxygen at 15 liters per minute. And also before intubating, you need to do a risk-benefit analysis, deciding when and how to intubate. And the most experienced operator should perform the laryngoscopy. This is another thing that might be useful in intubating a pregnant patient. The normal supine position obviously makes it difficult. Therefore, using this RAM position, where you use a couple of pillows under the neck and the shoulder, might have a RAM position, make it easier for you to intubate a patient during pregnancy. So that's about intubation. Then we come to breathing. I won't focus too much about breathing because there's going to be another talk talking about ventilation. But very quickly, what happens during when pregnancy is that there's increased respiratory drive. Because of the increased respiratory drive, the respiratory rate doesn't increase, but the tidal volumes increase. So there is some amount of respiratory alkalosis. There is a mild respiratory alkalosis during pregnancy, and this might then limit the ability of the patient to compensate for metabolic acidosis if it occurs later on. Also, there is increased oxygen consumption, and therefore the SCVO2 is low in pregnant ladies, and this may not be a great indicator of tissue hypoperfusion as compared to non-pregnant women. So these are the two things that might happen. Obviously, I've already talked about their decreased FRC, which makes them tolerate hypoxia much lesser. There are several reasons why pregnant women may need ventilation. Really, these are all the reasons. I won't go through them. But so you have different options. I think Dr. Pandit will talk about them in more detail. So we can have either an NIV, which has its advantages and disadvantages. There are some concerns. So I think this will be discussed later on. Nowadays, of course, we can also consider high flow nasal oxygen in the pregnant lady, which was an option, at least because we are worried about aspiration when they're using NIV. And of course, mechanical ventilation pregnancy poses its own, challenges. But we have again, like I said, Dr. Pandit, I think is going to talk more about this. I really won't talk too much about all these things. About the chest wall compliance, also, I think I'll leave that to him. So a bit about sedation and neuromuscular blockade in the ICU when you're ventilating this patient. There is no completely safe drug. You need to balance the risk versus the benefit. Opiates are probably the most okay, because benzodiazepines have been theoretically class D. That means they're theoretically contraindicated in pregnancy unless their benefits far way outweigh the risk, because they cross the placenta and potential problems. Propofol probably in the short term is okay. Maybe for the incidence of propofol syndrome might occur if it for a longer time. Neuromuscular drugs also cross the placenta. So whatever you're using at the time of delivery, we need to warn the neonatologist that the patient has been exposed to these drugs and the child might be having the effects of the sedation and paralytic agents. Then we come to circulation. So what are the cardiovascular changes that occur during pregnancy? Basically, the heart rate increases, the stroke volume increases because of an increase in blood volume. And because the placental circulation is a low circulation, there's a decrease in peripheral vascular resistance. So therefore, as a result of an increased heart rate, there's a decrease of an increased stroke volume, and because of the decrease in the peripheral vascular resistance, the cardiac output increases. But this increase in cardiac output and increase in heart rate may not be tolerated very well in patients who have, rheumatic heart disease or heart disease. So they might decompensate. Obviously, that you all know, they might decompensate during pregnancy. This is something that we need to be, aware of. Also, pregnant women usually have a lower blood pressure and a faster heart rate because, like I said, they have a lower vascular resistance and they already have tachycardia. So because of this, physicians may not recognize an impending shock due to critical illness. And pregnant women may lose up to 1.5 liters of blood before there's any manifestation of clinical signs. And hypotension is a very late sign in pregnancy. And in fact, blood loss in the mother may first be reflected as fetal distress. So actually monitoring the fetus might reflect maternal, shock or hypotension. A rising heart rate is an early compensation for hypovolemia. Therefore, a maternal heart rate greater than 100 beats should be considered sinister unless proven otherwise. I understand pregnant women, they have a tachycardia, but if it's going more than 100, especially if it's increasing, you need to have a slightly low threshold for diagnosing something sinister. Also, we must understand that pregnant women are susceptible to pulmonary edema. though there is no increase in the baseline pulmonary wedge pressure despite this high cardiac output, because the ejection fraction is intact, afterload is reduced. So the baseline wedge pressure does not increase, but colloid osmotic pressure is reduced. Therefore, this makes them more vulnerable to pulmonary edema. And pulmonary edema will be easily precipitated either if there's an increase in cardiac preload, like such as if there's a infusion of fluids is not judicious. Injudicious use of fluids can cause specific pulmonary edema in the pregnant lady. And you must understand that the traditional criteria volume responses like the PPV, the stroke volume variation, the IVC diameter are unreliable in pregnancy because of the uterus pressing on the the veins in the abdomen. So they're really unreliable. But it has been said that the passive lung raising test is a reasonable indicator of fluid responsiveness. But how practical it is to do the PLR in a gravid lady is debatable. But if you can do it, it's supposed to be reliable. But all the traditional indices of fluid resuscitation, of fluid responsiveness may not be that reliable in pregnancy. Of course, also, in patients who have increased capillary permeability, like in preeclampsia, again, they're more vulnerable to pulmonary edema, even with, like I said, with injudicious fluid administration. So we need to be a little careful when administering fluids to patients in pregnancy. Also, this is a bit about, the uterine placental flow. It has autoregulation. That means when the blood pressure drops or increases, blood flow to the placenta is regulated. But the limits of autoregulation are not very broad. So though the placenta can autoregulate, it does not have a great capacity to autoregulate. The limits of this are not very, not very broad. Therefore, hypotension can cause placental ischemia, fetal ischemia, and hypertension can cause abruption, can cause bleeding in the placenta. So we need to avoid, too much of hypotension or too little or too much of hypertension. So you need to use a vasopressor judiciously. So though most vasopressor drugs alter uterine blood flow, but you need to balance this risk versus the requirement of resuscitating the mother. So most often hypotensive mothers, you will have to obviously use a vasopressor to increase the blood pressure. But you obviously need to therefore use invasive monitoring. You need to both monitor the mother and you need to monitor the fetus to make sure that your vasopressor is not doing any harm to the fetus. At the moment, the first line vasopressor is supposed to be norepinephrine, is the first line agent of choice for hypotension. And some articles seem to say that phenylephrine is probably preferable to norepinephrine because it's a pure alpha. Arginine vasopressin is uterotonic and therefore not first line used in pregnancy. And though adrenaline was previously used as a first line drug, nowadays because it causes fetal dysrhythmias and lactic acidosis in the fetus, it's not used regularly in pregnancy, but might be used during pregnancy and CPR, but not routinely used in pregnancy otherwise. We all know that in labor, there is an increase in the cardiac output because there's a lot of blood returning to the circulation during contractions, and patients who already have an underlying heart disease may not be able to tolerate this. They may decompensate during labor. Then another thing that is, of course, reasonably well known is the supine hypotension syndrome, especially in the third trimester, because the gravid uterus presses on the aorta and reduces the blood on the vena cava and reduces on the vena cava reduces the blood, return of venous return. So in patients who are hypotension during CPR, you probably need to turn them in the lateral position. You need to keep the left side slightly down, which means you need to keep something above the right hip to keep the left side down at about 25 to 30 degrees down to reduce the weight of the the uterus from the IVC and the aorta. So and to increase blood flow to the venous return. This is an important thing in patients who are hypotensive, especially in the third trimester, recognition of the supine hypotension syndrome. That brings us to CPR in pregnancy, where this becomes an important consideration. The causes, of course, some pregnancy, there's some causes of CPR that might be unique to or fairly common in pregnancy. The causes of pregnancy-related cardiac arrest are severe bleeding, preeclampsia, pulmonary embolism, amniotic fluid embolism, and trauma. So basically, but when you're doing CPR in pregnancy, the resuscitation algorithms are more or less the same. There is no change. Previously, people used to recommend a slightly higher site for chest compression during pregnancy, but now it's recommended the site for chest compression is the same because the heart doesn't move up. It moves to the side. It doesn't move up during pregnancy. And obviously, like I said, during cardiac arrest resuscitation, you need to, displace the uterus manually because, you can't give left lateral. You need to displace the uterus manually to improve venous return. IV line should be used only above the diaphragm because I understand getting lines during CPR might be difficult, but a femoral line may not be very useful because of the pressure on the IVC and it may not actually reach the circulation. So it's always better to use IV lines above the diaphragm, especially during CPR. And after 20 weeks, if within 4 to 5 minutes of CPR If spontaneous return of circulation does not occur, we need to consider an emergency cesarean delivery, because then you might be able to remove the weight of the uterus and improve venous return. So this is a consideration during CPR in pregnancy. Within 4 to 5 minutes, things don't improve, consider an emergency cesarean. Now, already talked about the GI tract in pregnancy and its implications in the ICU. Basically, because of the increased progesterone, the lower esophageal pressure is reduced. Because of the pressure on the gravid uterus on the stomach, the gastric pressure is increased, and the gastric motility also is decreased. So all these three contribute to an increased risk of aspiration. So we need to know that when you're in the ICU, that also might be consideration when you're thinking of using NIV, or of course during intubation. Another thing that we need to know about is that in pregnancy, what happens is that because the cardiac output is high, there is increased renal blood flow. The GFR actually drops. It is something like an augmented renal clearance. And as a result of this, the clearance of most drugs is actually higher in pregnancy. Which basically means we need to be careful about dosing our drugs. We need to be careful that we're not underdosing our drugs, especially antibiotics. It is something like the augmented renal clearance that we talk about in sepsis. So pregnancy is something similar to that. We need to be careful that we don't underdose our drugs, especially antibiotics, because there is both increased clearance and increased volume of distribution because of the high cardiac output. We make sure that we don't underdose our drugs. And the second thing we need to know about that is that creatinine tends to be on the lower side. Therefore, actually, even a normal creatinine in pregnant lady should make you worried whether this patient really has renal failure, because normally the GFR tends to be on the lower side. The other thing that we need to know is that pregnancy is a pro-coagulant condition. So lots of the factors, factors in pregnancy change. So, the protein C, protein S actually decreases, makes them, more hypercoagulable. A lot of the protein factors increase, making them more hypercoagulable. So basically, pregnancy is a pro-coagulant condition. You need to consider, in the suitable population, you need to consider anticoagulant VT prophylaxis. So which patients in pregnancy is VT prophylaxis indicated? Obviously, in patients with a prior history of venous thromboembolism, if the patients are hospitalized for an acute illness, and patients who have an inherited thrombophilia. And, the incidence, of course, is most increased, though it is increased throughout all trimesters of pregnancy, it is the highest during the postpartum period. And it's better to use heparin or LMWH-based regimen rather than safer than the oral anticoagulants. And LMWH rather than unfractionated heparin provides, is probably preferred, provided the patient does not have renal insufficiency. That is probably the anticoagulant of choice for prophylaxis during pregnancy. So this is, Sharmili asked me to summarize everything in one slide. I think this is more or less the summary of what we have talked about: the cardiovascular changes, the airway changes. Also, that they are prone to sepsis because of immunosuppression, and because of the loss of the urethral sphincter tone, they're more prone to renal infections. And of course, I've talked about the hypercoagulability and the risk of VT and PE. Thank you. So I think I've left some time for questions if there are any. Thank you.
Thank you, Dr. Hegde, for an excellent and a very precise talk and summarizing the changes in pregnant patients, about the physiological changes in pregnancies and its relevance to critical care. I would request the chairpersons to put up the questions if they have any. And I think there are a couple of questions in the chat box if you want to put across for discussion, please.
Yeah, good evening again. Thank you, Doctor. Just I want to little add some points. Just in pregnancy, the pH changes or the ABG in a normal patient, PCO2 is increased because of the hyperventilation, and oxygen tension is more than 100, and bicarbonate is always less, around 20. That's another thing that happens. Unless there is some comorbidity, our God has made women in such a way they compensate all the changes, because it develops very slowly. So when there is a comorbidity, all problems do occur. See the chat box. I don't see the chat box.
There is a question for Dr. Hegde. There is a question from a doctor regarding the impact of critical care medicines and procedures on a pregnant lady. I think it's too vast, but if you would like to summarize few points in nutshell.
No, but medicines, like I said, that most of the drugs, no drug is absolutely safe. Most of the drugs come under B, C. I mean, there are some drugs which are D, but most of them come in category B or C. So no drug is absolutely safe in pregnancy, but so you need to balance the risk versus benefit. Like I said, all the sedatives that we use, probably the narcotics are used okay. Propofol is okay. Dexmedetomidine is probably also okay. But you need to inform the neonatologist if it happens during delivery that the patient has been exposed to these things. Benzodiazepines have been relatively lower down. They're actually category D. So also the neuropalatic agents, both scoline and rocuronium, have been used in pregnancy. And again, the neonatologist needs to be informed if this happens during delivery. So for every drug that you use, it is a risk-benefit ratio. Of the vasopressors, as I've already emphasized, probably norepinephrine, phenylephrine are preferred over the adrenaline and dopamine. And procedures, basically, like I said, you try to. I mean, obviously, like I said, if your monitoring, your standard monitoring is acceptable, but your traditional indices, again, I have to refer to them in my talk. The traditional indices of fluid responsiveness are probably not very great in pregnancy. So otherwise, there is no the standard procedures, standard monitoring procedures are okay. The usually invasive lines, but if you have to use fluid responsiveness, but like I said, in pregnancy, you probably need to be a little cautious about fluids. So it's a balance between fluid and vasopressors. So for everything, as in medicine, it's always a risk value. Evaluating the benefit versus the risk. There is no absolutely safe or absolutely unsafe.
Right, so, just for the benefit of also, we have. I just like to inform you that there are a few obstetric and gynecologic postgraduate doctors and even the consultants have joined us this evening. For their knowledge sake, would you like to say a few lines about the effect of invasive mechanical ventilation on pregnant women?
I thought Dr. Pandit was going to talk about ARDS ventilation, which is why I didn't.
Physiological. I mean, for not non-ARDS indications, in short, if you want to. I mean, I think some gentlemen.
No. Basically, I said that one is that because of the pressure of the uterus, the compliance of the chest wall actually decreases. Which means in these people, actually, when you are ventilating, normally I've been taught that you should ventilate them at a tidal volume at a pressure of less than 30. But maybe in these people, you can have a higher pressure because the transalveolar pressure is probably going to be normal. So you can probably afford a slightly higher pressure because the chest wall compliance, either because of the obesity, because of the diaphragm being shifted upwards, all these things reduce the chest wall compliance. So maybe you might be able to ventilate them it's not completely wrong to ventilate them at a higher pressure. That is one thing that we need to talk about. Second thing is in hypoxia, normally for, when you're ventilating people, our targets for oxygen about 55, but in pregnancy, you probably need to have a higher target. You can't accept 55 PO2 in the ICU, we accept 55, but here maybe 65 and above PO2 is required. You need to have slightly higher oxygen. And both hypercapnia and hypocapnia, both are dangerous, but of the two, probably hypocapnia is a little more dangerous because hypocapnia reduces, placental blood flow. So you probably should not have low CO2. High CO2 also might be, dangerous, but probably people have said that mild hypercapnia probably is tolerated well by the fetus, but it might be difficult to maintain normal capnia in difficult lungs, but probably between hypocapnia and hypercapnia, you should try and avoid hypocapnia more than hypercapnia, but otherwise the principles are more or less the same. So,
thank you very much, sir. I think that was a very important and pertinent point about avoiding hypoxia in this population of critically ill patients. So oxygenation is very important for pregnant ill patients when especially they are falling critically ill. So in that context and maintaining the flow, we'll move on to our second session, topic of the session tonight. That is about oxygen therapy in obstetric critically ill patients. For this, we have Dr. Rajesh Chandra Mishra. He's a renowned intensivist and medicine specialist. He needs no introduction actually, but I would definitely take pleasure to introduce him. He is the president-elect of Indian Society of Critical Care Medicine. And recently he has been elected as the national representative of India for European Society of Critical Care Medicines. He's chairman of scientific committee for the upcoming Critical Care 2020 in Hyderabad. And he's been editor of the RRT and acute kidney injury guidelines, the textbooks. So over to you, Dr. Rajesh Mishra. And I would like to, just 1 minute, I would like to invite the chairpersons for this important sessions. Dr. Professor P.K. Mishra, Prasanna Kumar Mishra, he is the Honorable Chairperson of ICCM Cuttack branch. And would like to also invite Dr. Sarosh Patnaik, Senior Consultant Critical Care Medicine, Apollo Hospital, Bhubaneswar. And Dr. Saurabh Kaule, sir, if he has joined us, He is a senior intensivist and emergency medicine specialist at Bellevue Clinic, Kolkata. And for all those who have joined us a little late, I would like to again welcome you all on behalf of the ICCM Cuttack branch and Apollo Hospital, Bhubaneswar. Over to you, Dr. Mishra.
Thank you, Sharmili, and thank you, Dr. Mishra, Dr. Kole, for the sharing this session, Dr. Patnaik. Before I go to the main talk, oxygen therapy, the one thing is what Dr. Hegde has spoken. He has really lightened my talk. He has done some part of the job which I had to do, and will easy for me to tell you why oxygen therapy is important. What we had done that before I go to main talk, is I'll share the story that during COVID 1 and 2, we had dealt with around 20 patients who came to us with pregnancy. Luckily, all survived. And since the relatives and patients were very anxious, the moment they had symptoms, they came to us very early. Most of them responded very well with, they needed oxygen very early because they used to become tachypneic very early. They used to become hypoxic very early. And what we tried to maintain the exactly same, what ABGR, what oxygen levels should have, what they had before pregnancy, because these patients are mildly alkalotic, their PCO2 is on towards lower side, their PO2 we have to maintain around, here the target we maintain around 95 and above, because fetus also needs oxygen, so we cannot really go to the 92 and less. So with that, most of the patients did well with the therapy of remdesivir and dexamethasone. Few patients really needed high flow, and those patients who needed high flow, they also responded very well to therapy of the immunomodulator. So, but we did not see any lose. So we did not see any patient dying because of the COVID. So the best part about the pregnancy with COVID was that our outcome and salvageability were good. Probably they came to us in early. So with this, coming to the my main component of treatment, that is oxygen therapy in COVID. As we know that the COVID predominantly, although it's a multi-organ dysfunction disease, involve all endothelin, but predominantly it involves lungs, and it causes the inflammation leading to the acute lung injury. Receptors are mainly AC receptors, and depending upon your immune response, depending upon the damage to inflammation and lung injury, one gets symptom. And based on that, there are 3 different phenotypes have been described, and same applies for the pregnant patient as well. And those phenotypes are, there are predominantly interstitial pneumonia with pulmonary hypoxic vasoconstriction. Other group are there is a diffuse alveolar damage, and other group is that predominant fibroproliferation. The patient who has like less of the extracellular, less of the symptomatic, or they are not very symptomatic, those fall in the group of the interstitial pneumonia with predominant endothelial, either with pulmonary vascular involvement in form of thrombotic. These patients are not that symptomatic, though oxygen drops. But other groups, like where alveolar involvement is huge or interstitial proliferation is very fast, these patients become symptomatic. What we have seen that mostly these patients who came to us in pregnancy were in the category of interstitial pneumonia involvement in form of pulmonary vasoconstriction involvement. As far as clinical manifestation was concerned, their predominant symptom was cough, fever, followed by feeling of breathing distress, though they were not like typical happy hypoxia symptoms were also here. Their saturation used to drop, but since most of the patients whose saturation dropped below 95, they reported to us early, because these patients were very vigilant, and most of the pregnant patients were very vigilant. The doctors were also that vigilant, that reported to us early. So they really became reported to us well before they really became symptomatic. As far as severity of clinical finding was that severity is concerned, maximum what we had seen is that the saturation dropped to around 85, responded well to NRBM, few needed HFNC as well. But There are reports where patient has gone to severe hypoxemia, needed ventilator support, even needed inotropic support, and even needed ECMO. So the severity may vary from the mild hypoxia, asymptomatic patient, mild hypoxia, moderate hypoxia, needing different gadgets which are coming, to the severity like needed intubation and even some of them needed ECMO. The effect of COVID-19 on pregnancy and perinatal is not very well studied because it's not typically like what is to happen with H1N1 ARDS. We did not notice anyone has to deliver we have to deliver forcefully to improve oxygenation, because as I said that most of the patients who came to us responded early, but there are patients where hypoxia was resistant, where they needed more support, where they needed frequent proning. Delivery of the fetus has helped them, these patients, in oxygenating and ventilating well. So what are the anatomical and physiological change which happens, which affects oxygenation and oxygenation as well as cardiovascular stability in this patient? And Dr. Hegde has already explained that there are certain changes which happen, that is the increase in cardiac output, increase in blood volume, and increase in total cardiac output. So they are already at the margin of physiological well compensation, and that compensation in full-term pregnancy is up to the maximum. So anything which further stress them will lead to the symptomatic presentation. So these patients are tachycardic, these patients are baseline tachypneic, these patients. So they have to keep this issue in mind. And these patients, even mild symptom, which a young patient may tolerate, this pregnant patient may not be able to tolerate because of they're already working at the very at the margin of their physiological result. So that's one factor. So this patient may have shock early, this patient may have tachyarrhythmia early, this patient may have hypoxemia early. The reason being, there are changes in chest wall compliance as well as lung, and this leads to increased chest wall compliance. As Dr. Hegde said, not only chest wall compliance, there is a reduction in functional residual capacity, there is less oxygen reserve, though the vital capacity remains unchanged. Tidal volume increases because they have to hyperventilate, but the total functional residual capacity is less, and this is key factor that these patients become hypoxemic very fast. So whenever a COVID patient who may even be at a clinical stage of just mild, but they may become more symptomatic and more hypoxemic and may need early support because they have less of the cardiopulmonary reserve. So that's one issue which we have to keep in mind. The symptoms, they have been typically divided based on their oxygen requirement in form of asymptomatic, mild, moderate, severe, and critical. I will not touching the part of the critical because that comes under that will be covered by Dr. Pandit, which will when he will discuss about the ventilator strategy. But as far as concerned with the mild, moderate, and up to severe, by timely intervention of appropriate oxygen gadgets, one can, and other supportive measure, one can reverse the process if this patient responds. So based on the oxygen requirement, based on the symptom, and based on the hypoxemia, these and clinical symptoms, these patients are divided on mild, moderate, severe. How to intervene with what gadgets and what are the available options for them is that I'll come. But what we have to remember that 80% of the COVID patient in general and even in pregnant patient has a mild symptom and they just recover without much of the intervention. Those 15, another 5%, they become critical and they need all kind of gadget. These 15% of the patient who goes from the mild disease to moderately severe and severe, with appropriate oxygen therapy, they can be treated or they can be even reversed back to the normalcy. So what are the gadgets available for oxygen therapy? It's like we have nasal cannula where you can give up to maximum 6 liter oxygen. The 6 liter means you can add another 14 to 60% oxygen to the requirement. What we have to remember, maybe it is venturi up to 50%, maybe it is rebreathing mask, which can give up to oxygen up to the 90 or 100%. You have hybronasal cannula where you can increase flow up to 6 liter with 100% oxygen. And then coming to the non-invasive ventilation and intubation. What is the most important thing? Whatever gadgets we give, we have to remember that not only oxygenation should improve, but their work of breathing, tachypnea, and other hemodynamic stability should also, like these patients are very anxious, their oxygen requirements are very high. So whatever intervention we do, We need to monitor that by giving oxygen in whatever way we are giving, they are showing signs of improvement. If they are not showing signs of improvement, then they quickly need to upgrade. Like many times we just give a major prong, there is oxygen with 4 liter, they respond, and then suddenly they come back to the previous stage, they have oxygen saturation drop. So here we don't need to wait, because what we have witnessed, that oxygenation status and oxygen improvement is not the same which happens in non-COVID ARDS. Here, the mechanism of hypoxemia are multifactorial, and even you may see some sign of improvement in giving oxygen initially, but later on they deteriorate. So you need to be continuously vigilant, and before this patient becomes symptomatic due to hypoxemia, you have to intervene with better gadgets and intervene early. Because once this patient goes down, they deteriorate very fast and become difficult to get them back to the normal. So here is the overall process, how you, our targets in normal target was 92, but in pregnancy, we kept a target up around 95%. We started with the nasal prongs. If not responded, we went for the NRBM face mask, monitored if oxygenation and tachypnea tachycardia improve is fine. Otherwise, immediately we went for the high flow nasal cannula. The target always remained 95% and plus. One particular factor, that is awake proning, which was done in routine patients, was not possible to do in full-term pregnancy. But what we did to avoid the venous compression, we asked them to lie maximally, which was possible to achieve in some patients around 50% time. They could lie on either other side, particularly left lateral position, and that has helped us in elevating the hypoxemia as well as elevating the improving the oxygenation status. So we could not do the complete proning in awake phase, but we did the lateral positioning in this patient. If optimization of high flow and how to optimize HFNC, I'll come into that. It doesn't work, these patients should be given NIV early. And if that also doesn't work, we do not allow hypoxemia or hypercapnia and deterioration, they should be intubated early. Post-intubation, definitely, even in full-term pregnancy, with the help of pillow and with the available gadgets, till the baby is delivered, even port positioning can be tried, and it has helped. So what is most important when we fail to oxygenate them with the NRBM is go towards high flow nasal cannula. High flow nasal cannula start with, although it's not possible to achieve 100%, but 90%, 95% oxygen. You start the gradual flow and you can go flow up to 60 liter. Although there are some HFNC which gives up to 80 liters of flow, but 60 liters is common. And if that achieves your 95% oxygen, if that elevates your tachypnea, tachycardia, it's fine. If it doesn't, then quickly you should. What is the most important thing here is that we monitor them with the, although the ROX score is mainly for the anyone who was on HFNC, there is a timely improvement in ROX score. It's over 2 hours, 6 hours, 12 hours, and above 12 hours. The ROX score is a SpO2 divided by FiO2 divided by respiratory rate. And as time passes, this ROX score should, the predicted ROX score, and it should be that predict that your HFNC will work or it will fail. So if you have started somebody and if your breathing improves, your oxygenation improves, your ROX score is likely to get better and likely to increase. So if your ROX scores do not increase or it reduces further, like suppose at 6 hours it was predicted to be less than 3.47. So it is absolutely fine to have this. But suppose this was 3, or suppose this was less than, this patient is likely to fail HFNC and get intubated. So every 12, we can just objectively monitor the progress by ROX score and predict that this patient is going to fail HFNC or going to tolerate HFNC. So one can have a protocol at 2, 6, or 12 layer when putting HFNC. If your ROX score goes at 2 hours above 4 point like that, you continue monitoring, continue support. If it fails, you adjust the settings, see if there is improvement, no improvement, intubate. So ROX score was one of the very important scoring system which came only for objectively identifying those patients who are going to fail the failed the HFNC, and even for though not very successful for NRBM, but even people tried it for non-invasive ventilation, but mainly it was for the high flow nasal cannula, and it predicted early that this patient is going to fail and we have to intubate. So one can include this protocol for their monitoring. So what we do for all pregnant patients for oxygen therapy, give oxygen, initially start oxygen with the mask on nasal cannula, targeted 95%. Monitor, if it's not improving within 30 minutes, we shift to the non-breathing mask up to 50 meter NRBM. If that doesn't work, immediately we shift to high flow nasal cannula and we can go up to the 95%, up to the 60 liter. If it improves over oxygenation, oxy score goes improves as well, we continue with the treatment. If it fails and doesn't show the improvement, then we either quickly shift to NIV or quickly intubate this patient. We did not. Although I was lucky enough I did not have to intubate any of the pregnant patients. But if I have to intubate this patient, probably at that time, I also considered delivering the baby to have further aggressive treatment for them. With this, thank you for all your attention. I'm open for any questions.
Thank you, sir, for such a nice talk. I don't think there are any relevant questions in the chat box, but I just want to know, like, your take on, like, when you are at times we receive patients around 6 to 7 months, 7 to 8 months gestation, COVID positive, whether you go for early termination or
no, we did not terminate. As I told you, we did not terminate anyone who responded up to HFNC. And as I said that around our experience was none needed termination of pregnancy. We tolerated pregnancy very well with appropriate treatment and high flow nasal cannula and big toci. I remember we had to give tocilizumab around in 4th patient, and all the patients who delivered later on, it was a safe delivery. But there are case reports where when they needed intubation, the hypoxia was bad. They needed termination of pregnancy, as well as few patients needed ECMO. And even there are reports of safe delivery of baby at appropriate time with the help of ECMO also in COVID patient. So these are the occasional case reports, but we did not have to do anyone. So depending upon, it is like, we are learning with COVID, and it is just depending upon the clinical condition and physiological progress, one has to take decision. What bottom line we have to remember that maintain the same physiological PS, PCO2, PO2 bicarb what patient has pre-pregnancy, because these changes are important for the fetal perfusion. So though whenever it comes to the balancing between mother and fetus, we try to save mother, not fetus, but the rule remains that we try to achieve same. So we do both monitoring of mother and fetus both continuously. And we try to achieve the same, particularly same physiological variables, same pH, what patient had before pregnancy. What is the normal before pregnancy? Before the disease in pregnancy, sorry.
Thank you, sir.
Yeah, thank you, Dr. Mishra, for such an elaborative and which was tinged with your own practical experiences. And thank the chairpersons, Dr. Saroj Patnaik and Dr. Kohli and Dr. Prasanna Mishra for chairing the sessions. So you have now talked about this oxygen therapy in obstetric critically ill patients with COVID-19 disease. And at the extreme of this illness, patient usually land up in respiratory failure. And that's what we call COVID-associated acute respiratory distress failure. It's been commonly known as CARDS, COVID-associated respiratory distress syndrome. So on this, to talk on this very important and crucial topic of ventilation for patients who have been affected with this ARDS, specific ARDS, we have very eminent speaker, Dr. Rahul Pandit. He is a HOD and Director Critical Care of Fortis Hospital, Mumbai, and is currently the Vice President of ICCM. And he's a visiting consultant in Australia in critical care. And to chair the sessions, I would like to invite Professor Dr. Rekha Das. She is currently the chair secretary of ICCM Cuttack branch and also president of Indian Society of Anesthesiologists of Odisha. Ma'am is a in charge and professor in the Department of Anesthesia Critical Care Pain in Acharya Hariyar Institute of Cancer in Cuttack, and also a consultant in critical care in Santi Hospital, Cuttack as well. We have, I'm not sure if Dr. Manoj Patnaik has joined us. He's a very renowned senior pulmonologist of the state with national repute as well. He is the in charge and HOD of pulmonology at Department of Pulmonary Medicine at SM Medical College, Cuttack. And we also have senior consultant critical care, Dr. Jyoti Narayan Sahu, to chair the sessions. So with that, I would request to Dr. Rahul to please proceed. Thank you.
Thank you, Dr. Sharmili. Just to clarify, I'm not the vice president of ICCM anymore. I used to be the vice president in February. I'm not a part of the EC now. But thank you very much for the kind invite. And, I was very delighted that you actually gave me this topic because we are a high-risk obstetric unit. And, while people would have seen cases and case reports, I thought, why not start with the two cases which I have in the unit ICU right now. So case one, 33-year-old female, delivered on 9th of September and was straight away referred to us in our hospital. Diabetes mellitus, preeclampsia, symptoms from 1st of September. And she had very severe CT changes on admission. This was the immediate post-delivery CT scan, which was done in the emergency department in the hospital. That was her ABG on admission. She had a respiratory rate of 30. This was on NRBM when she came to us. PaO2 of 83, PCO2 of 82.5. We obviously intubated her, gave her prone ventilation for a couple of days, which was already delivered. Then we decided to go on ECMO because which was just difficult to sort of oxygenate this lady. We extubated on day 7 and then removed the ECMO on day 10. And today this is her X-ray and she's ready for discharge in a day or two. Another lady which is there right now as well in the ICU, 38-year-old, twin pregnancy at 28 weeks of gestation, a complete placenta previa, symptoms since 8th of September, referred to us with severe ARDS. This is an X-ray on the intubation in the emergency department. We intubated her, and essentially with 24 hours of trying to ventilate her, we could not actually improve her hypoxia. She continued to have progressive hypoxia. So I actually delivered the child. It was a twin pregnancy. Both the babies are now 1 and 1. One is 1 kilo and the other is 1.1 kilo. Both of them are now just been extubated a day or two before and are on CPAP in the NICU. We ventilated her prone for 5 days. After that, we were able to do a tracheostomy, however, just not able to wean. Severe respiratory distress again, severe hypoxia. 2 days ago, I put her on ECMO and listed her for a transplant, hoping that over the next 7 or 8 days or 10 days, maybe let's see what the ECMO shows in terms of her improvement. And then we will decide whether to do a transplant or not. These are the two cases which I have right now in ICU. This was her CT scan before the ECMO was initiated. This was the ABG today. On ECMO, still she has a PF ratio of only 100. Very large amount of VQ mismatch. She's on a VV ECMO currently, and she still remains on a 70% FiO2 on ECMO. This is just a picture of the cubicle in which she is right now. So a lot has been discussed about physiological changes of pregnancy. And I think this is where the most important aspect is when you have a patient who comes in with COVID-associated ARDS or even an ARDS of any other factor, any other reason. Over the last 10 years, we've had several patients, several pregnant ladies been referred to us. As I said, they're a high-risk obstetric unit. And we have done it all. We have intubated them. We have delivered the patient in the ICU. We've done cesarean section in the ICU during the cardiac arrest. We have proned the patients after delivery. We have put them on a high-frequency oscillatory ventilator when they were being used in the early 2013, 2014. And we have put them on ECMO. We have tested them for heart transplant. We have done a heart transplant. And now this is a lady we have actually listed for a ECMO, for a lung transplant. which I'm hoping we don't have to do, and she should just sort of escape out of just with an ECMO support. So the problems are there is increased oxygen consumption and carbon dioxide production. Obviously, there is a decrease in the bicarbonate as well as the PaCO2. If you give them too much saline or stuff, they quickly go into hyperchloric metabolic acidosis. There's increased work of breathing. Their functional serial capacity is extremely poor. There's decreased tolerance of apnea or hyperventilation, and there is airway swelling. There's also maternal fetal oxygen consumption, which sort of increases to 40 to 50% over the non-pregnant state. We all have talked about Dr. Hege and Dr. Mishra have talked about the cardiac output changes. The FRC changes is one which actually pertains to these patients who get ventilated, intubated here in the ICU. And they have a very, very diminished capacity to tolerate apnea. This is the kind of comparison which you can do for a FRC. They just don't have any capacity to actually tolerate an apneic spell. Their FRC is so down, sometimes it's down at half than what normally one would have as the pregnancy progresses, and as it reaches beyond 36, 37 weeks, that's what you get, almost less than half of the FRC what normally one would have before. I think Professor Mishra talked about the ABG changes. We do know that there is a oxide which goes down PaCO2. PaO2 remains more or less same. pH remains more or less same. They do have a small amount of compensation mechanism going on with the bicarbonate there, and the bicarbonate remains around 18 to 20. This is what basically happens as a compensatory mechanism by the mother to compensate for all the changes which have happened in there. What are the principles of managing these patients? When they come to you in a severe ARDS, obviously I take it that they have been tried on high frequency high flow nasal cannula. They have been tried on NIV, and now they have come to a point where they need to be intubated. Or sometimes they come to us and they have not been tried on any of those modalities, and we need to think of starting with an HFNO and maybe think of NIV, and there are some limitations of NIV. But the standard of care does not change. It's challenging to achieve that. The low tidal volume, the plateau pressures to be kept low, the PFIO2 table to be used to the best without compromising on the fetal circulation. Prone ventilation is almost impossible to do in a full-term pregnancy. The pregnancy is below 26 weeks, 24 weeks. I think usually you don't have a lot of problems. It is a 28 weeks plus pregnancy which actually gives you a lot of grief and concern. Sometimes deep sedation, neuromuscular blockade, though you can use some of these drugs quite safely, it does cause a problem when you're about to deliver the baby. And as I said, 28-week plus is a difficult thing. The definition, the Berlin definition does not change. We all know the Berlin definition, and it remains the same to sort of categorize them between mild, moderate, and severe. All of us, without fail, all of us invariably would actually try and put them on a high flow nasal cannula. Just to see if we can reduce the requirement for invasive mechanical ventilation. Generally the guidelines may be different, but I think the evidence gap, which is non-existent right now, may still continue to promote the practice of using this lovely modality, which has got a very good patient compliance, tends to improve the oxygenation quite well, and sometimes even lessens the work of breathing which the patients have. If it fails, the next step automatically becomes that you try and put them on non-invasive ventilation via face mask. And there are some problems here. The biggest problem is aspiration. Most of these women who are then above 28 weeks of pregnancy have got a poor gastric emptying time. They have a very little, margin of error where if they vomit and we are not able to actually throw the vomit aside, they will aspirate. There is really no clear benefit in this age group, in this subset of patients, where you can compare NIV versus invasive ventilation when the mother's life is at risk. Obviously, in terms of the fetal's life, obviously you would not want to put them on mechanical ventilation. But as always, and Dr. Mishra also mentioned the same thing, that it is the mother's life which takes the precedence when it is a challenge between mother and the child. The airway is swollen, so it's a very difficult task to intubate them. Dr. Hegdes has already mentioned about the frequency of encountering a difficult intubation in pregnant women. As you put them on NIV, and usually the NIV is not delivering moisturized gases, the oral cavity, the mucosa becomes very dry, and swollen dry mucosa is a disaster waiting for endotracheal intubation. So don't flog them too much on NIV. If they have to be intubated, intubate and go ahead and deliver the patient within the first 24 hours. There is no harm in asking for a delivery of a patient because mother's life takes importance. The principles still remain the same. You try and give them 6 to 8 ml per kilo predicted body weight, try and keep the plateau pressures below. While the principles would remain the same, I don't know how easy it would be to achieve them without compromising on the pressures. So you will have to have the pressures which would probably go up. You may have to give a little bit higher tidal volume to sort of try and achieve the chest wall compliance to improve into the ventilation eventually. So I think the principles may not be very easy to sort of adhere to, but we do understand that if you have to increase the FRC, one of the best recruitment maneuver is prone ventilation. And I think pregnancy, a full term or a 28-week plus pregnancy does interfere into a prone ventilation, and it's not very easy to do a prone ventilation. I've had obstetricians before who would come and say, "You just prone, don't worry about the baby." But the fact of the matter remains that the prone ventilation further actually compresses onto the IVC and the aorta, and you would have more hemodynamic problems. You would have more problems in actually dealing with the patient who is prone and has a full-term uterus to actually deal with. So best is to go ahead and deliver the patient. I've done it many times now, and hand over the baby to a competent and neonatal intensivist to actually look after the mother. And that sort of helps. The Croseva trial has shown obviously the pregnancy was not a category in that trial. So the special consideration in this severe age group, a severe ARDS category of patients, their pregnant lady, is to deliver baby in a timely fashion. Don't delay it. Don't compromise the mother's life. If you deliver on time, there is actually a good chance that the mother as well as the baby will survive. And remember the cardiorespiratory considerations. I've deliberately not put them in because I was aware that Dr. Hegdes would actually cover all of them, and then subsequently Dr. Mishra has covered them as well. These are some of the case reports which Dr. Mishra was talking about. We've certainly got around 7 or 8 cases in COVID where we have intubated and delivered, and patients have gone home quite nicely. So it's not something which is unusual. People do it quite a lot. And I think as we see more and more COVID-19 cases, severe COVID-19 cases who get intubated, you may still have patients who would be required to be delivered electively. Remember, if you don't do anything, it's a disaster waiting to happen. Low lung volumes, low FRC, obesity, because they all tend to put on weight, and low threshold for apnea and hypoxia are usually quite bad. Thank you very much. With this, I would be happy to take up any questions, if at all there are any.
There hasn't been any questions, sir, but sir, how I would like to ask you, what is your experience on proning patients in the late trimester? Now, till what period of time you can continue with proning?
And if you have a patient who is about 28 weeks, I think proning is disastrous. I personally would not prone them after 28 weeks. I would keep them supine. After 20 weeks, a little bit of left lateral, right lateral. Maybe below 20 weeks, definitely you can prone them. It's not a big deal. But I speak with gynecologists, obstetrician, and we deliver the baby out. And go ahead and save the mother's life at that time. ARDS has got a very high mortality. And if you don't actually act on time, you are compromising with the mother's life. We are talking about severe ARDS who are requiring ventilation intubation. I'm not talking about a category where they are still been okay on a HFNO. But once they are to the point where the PF ratio has remained low, and despite best of your effort, the hypoxia just keeps on worsening and you intubate them, you will have to go ahead and deliver the baby.
And so regarding NIV with the risk of aspiration there. So
you can try. All of us try, madam. All of us try. Even I have tried that. But you don't flog them on for a long time. You take keeping them on very high FiO2 with an IV. The chest wall compliance does not actually allow you to have a lot of freeway there. So just intubate them and get on with the standard of care.
It's always a safer procedure to early intubation. That's a very good. So you spoke excellent, and I must really thank you for
Can I ask
relating your experiences on this.
There is a question in the chat box. I think the chat box has been flooded with questions even before we started our sessions. So I'm,
Yes.
classifying them as per the sessions. So there's a question for Dr. Rahul about, do you feel the physiological changes in pruning these pregnant patients are any different from those who are non-pregnant patients who are pruned?
Yes, Rakshami, that's what I'm saying. I try to prune postpartum patients after delivery. So the changes are reversing back slowly. The FRC is improving slowly because once you've delivered the baby out, most of your problems actually get solved. This I learned is quite early in when I was actually in Australia working. We had a H1N1 lady, and the moment we delivered her, all the pressures and the difficulty in ventilation just disappeared. I think that's what's very important. People are very, very skeptical in delivering. We should not be that skeptical in delivering. We should talk to our gynecologist. We should be able to justify it. Obviously, I'm not saying every patient needs to be delivered, but those with severe ARDS, if you're not able to ventilate them for a good 24 hours or so, I think you are risking the baby's life and you are risking the mother's life. If you deliver the baby on time, you will actually probably save both of them. Otherwise, you're going to lose both of them.
But this applies to patients who are more than probably 22 weeks and above they are pregnant. But
28 weeks.
Patients who are less than say 28 weeks of pregnancy, what about pruning them? I think with proper padding.
You can put them.
With proper padding and all.
Absolutely. Yes.
But the physiological changes, are they any different, do you believe, in this category of patients and patients
They
who are
have just started having the FRC reduction. They've just had their cardiac output up a little bit. The physiological changes have not really primed up to a fully pregnant lady still. So they are in 20 weeks or below. We are still able to manage those physiological changes to a reasonable level of their baseline, what would be a normal for a lady with 18 to 20 weeks of pregnancy. It should not be a problem.
So I think there are benefits, but they're slightly lesser than compared to non-pregnant patients.
Yes.
Okay. Regarding using thromboprophylaxis in a COVID pregnant patients, and whom, as you said, that they should be, always be encouraged to deliver early, engaging in
those prophylaxis for everyone in ICU. That's the norm. Just use it.
The same protocol that would like to follow.
Same protocol. There is no reason. In fact, pregnancy is a hypercoagulable state. You should be using a DVT dose prophylaxis definitely for patients who are in the ICU.
I think another question, both for you and Dr. Mishra, anyone can take this. Both of you have covered this. How frequently can one do chest X-ray or CT scan in these patients to assess the disease severity when they are either in the non-invasive ventilation or any kind of advanced oxygen therapy or invasive ventilation?
Mostly you don't need.
Absolutely, you don't need it. Severity actually can be calculated and looked at from just clinical parameters and arterial blood gas. X-ray avoided.
Yeah, I think it's a very basic.
If you are very good if you are having your unit well equipped with ultrasound, and if you are good at it, most of the time you don't need unless you are really suspecting pneumothorax or something, you have to intervene. Just for the assessment and routine assessment, you don't need X-ray or CT. Either if you are not pregnant also, we don't do in our ICU any X-ray. We just go on with it.
I think that is a common dilemma that many of the doctors in the peripheries face, and it is good that this question was raised by one of the doctors. Thank you very much, Dr. Rahul, for this enlightening talk. And with that, with the permission of chairs, can we proceed to the next session?
Yes, sure. That was an excellent talk by Dr. Rahul.
Thank you, ma'am. Thank you, Dr. Rahul. I think moving on to the next sessions, we have panel discussions on the unique challenges and learnings that we have earned from this COVID-19 patients and patients who were pregnant and affected with this illness. So I'll start sharing my screen for this purpose. I hope the slides are visible. So this is a kind of summative discussion on the management of this COVID-19 related critically ill patients in obstetrics, the challenges and learnings that we had in the last 1.5 years. For this panel discussions, we have a very eminent group of faculties today here. Dr. Professor George Hidalgo, he is from Belize. Dr. Deepak Govind from India. Dr. Rahul Pandit from India. Dr. Asina Jahanlopa from Dhaka, Bangladesh. And Dr. Ranjan Joshi from Adelaide, Australia. Just brief introduction of my panelist. Dr. Professor George Hidalgo is a professor of critical care medicine, and he's the recently president-elect World Federation of Intensive and Critical Care Medicines. He has so many achievements or accolades to its credit. He's a founder and head of Intensive Care Unit and COVID-19 Unit, Belize Healthcare Private Limited at Belize, is member of the SCCM Fundamental Critical Care Obstetrics, author of many chapters in critical care obstetrics, and has been into the administrative part of critical care and organizing critical care services in different parts of his country and across the globe. Next, we have Dr. Deepak Govind. He is the president, Indian Society of Critical Care Medicines, and currently the director and head of critical care medicine at Medant Medcity, Gurgaon. Dr. Asina Jahanlopa, she is the consultant and in charge intensive care unit at Samurata Hospital and Medical College at Dhaka. Her areas of expertise are nephrocritical care, sepsis and hemodynamic management to invasive and non-invasive mechanical ventilations. She is a member of Bangladesh Society of Critical Care Medicines and Board of Directors of International Society of Intravenous Anesthesia. Also member of Scientific Committee of Technosepsis 2021, which is going to be organized in Spain in November. And she has been the organizing secretary for first Indo-Bangladesh conference in the year 2019. And we are also blessed and fortunate to be joined by Dr. Ranjan Joshi, who is currently the Clinical Director of Obstetrics, ICU Deputy Director and Senior Consultant, Director of ECMO Services in Pediatric ICU Women's and Children Hospital, Adelaide, Australia. Is also the Director of ICU, the Memorial Hospital in Adelaide, Australia. So, my dear colleagues, before we proceed through the panel discussions, I'd like to cite a case we had actually treated in our unit a couple of months ago. So let's talk about that. Is a moderately ill symptomatic patient with COVID-19. She was 22 weeks old pregnant. She had a febrile illness lasting for at least last 6 to 7 days, and she had having mild cough. She was requiring 4 to 6 liters of oxygen. And among the initial blood tests available, she had a C-reactive protein, which was raised up to 65. D-dimer was 1.2. She was slightly tachypneic, not in distress though. And there was no other comorbidities like diabetes or hypertension. I'd request all the panelists to keep their videos open, please. So we'll just quickly go through what all drugs and investigations can be done in these patients. So my first question to Dr. Professor Hidalgo is about steroids. Would you like to use steroids in this case? And if yes, what kinds and what would be the purpose?
Yes, well, first of all, thank you for your kind invitation to this excellent presentations, and of course, congratulations to the presenter that for a very, very high academic presentation. And concerning the steroids, as you know, as in our regular patients, steroids has been recommended in this group of patients. We can use it in pregnancy, either if the patient is not hospitalized, but also in our particular case, in patients that are hospitalized. And most of the information, as we know, it came from the recovery trial. No? And just to be brief, basically the recommendation in those cases is to use dexamethasone 6 milligrams. But in case that we don't have dexamethasone, also we have other choices. We can use prednisone 40 milligrams. We can use prednisolone 32 milligrams, or we can use hydrocortisone 160 milligrams as an alternative.
So given a choice, suppose, what would you prefer? I mean, in the orders of priority, if you have to classify them, or you think all of them are equally efficacious and useful in this state?
Well, the trial and the recovery trial were done using dexamethasone, but also the other steroids have basically same efficacy.
Right. Dr. Rahul, your opinion on this, please?
So I think, look, I've been using only, so she would need steroids. There is no doubt about it. I agree with Professor George. Dexamethasone, I would personally be using only methylprednisolone 40 milligrams. That's what I have used for all my patients. But yes, recovery trial talked about dexamethasone, but my choice would be methylprednisolone 40 milligrams only. Is there any reason why I changed? No, that's what we have adopted as a unit policy. That's what I've adopted as my state policy. So that's what I'm doing. That's all.
Right. We in our practice actually used dexamethasone, or some of the patients actually, for the primary choice, we did use hydrocortisone in those cases. So all agree that steroids need to be used, and either the choice could be methylprednisolone or hydrocortisone or dexamethasone as per the recovery trial. And we have most of us have used that in our practice as well. So next, moving on to the next drug, because she is already.
Can I say something?
Say that, sorry?
Can
Yes.
I say something? So
Yes.
in pregnant ladies, dexamethasone is used for fetal maturity, fetal lung maturity as well. So does it has got any implication here as well? If we choose the steroid, so we can have three choices: hydrocortisone, dexamethasone, and methylpred. The only drug which has shown little benefit in the fetal lung maturity is dexamethasone, not the methylpred and hydrocortisone. So what the panel thinks, whether we should choose it or not. Dr. Ranjan want to say something, sir.
Please.
Yeah, no, I completely agree. And I know your recovery trial has definitely included some of the pregnant patients in that, but what's the recommendation is obviously it comes out with as dexamethasone or hydrocortisone or prednisolone. I was impressed that Dr. Pandit unit has adopted methylprednisolone. The doses has not been actually decided on that. But I completely agree with your point that dexamethasone usually when you're planning to deliver a baby premature for the lung maturity, and it can work like a double magic for you. So in particularly in the context of pregnant patients, my sole preference will be dexamethasone, and that's our NGX stance as well.
Yeah, point well taken, Dr. Joshi. And we used, in fact, dexamethasone in this lady. So coming to the other drugs, that is one of the antiviral drugs is usually thought of for these patients who is moderately ill and already requiring oxygen and in the intensive care unit. What about using antiviral drugs like remdesivir? I would like to ask Dr. Lopa to throw lighter opinion on that.
Thank you very much for giving me this wonderful opportunity in such an, I must say that's a very demanding topic today. And in this case, actually, that some government or society guidelines still include remdesivir for mild or moderate requiring low flow oxygen. But still the data supporting that the safety in pregnancy is not established about the remdesivir. And so in this case, actually, it would be prudent to not to use actually remdesivir because the case is moderate, I think.
Yes, yeah, right. So I think that's a very important aspect that you have cited. Remdesivir actually, it came with a bang when we're in the middle of the first peak, and it picked up, and there was shortage all over the world, and then suddenly trials kept on coming, and there were questions about its efficacy in reducing mortality of ventilator-free days. So it has gone through all kinds of criticism, and in its role in treating moderate to severely ill, critically ill COVID-19 patients with respiratory failure. But I think certain guidelines like the Royal College of Obstetrician Gynecologist of Britain still include this. And if you have to, you're considering the maternal life more important, some of them actually still leave a place for use of remdesivir. But I completely agree that probably its safety is not completely established. What is your opinion, Dr. George, on this?
It's exactly the same. No, the different trials that we did with remdesivir exclude this group of population. No? I mean that our the amount of patients we have is limited, but still in some cases, and we can still use it remdesivir. No?
Right. So it can be.
Can I make a point?
Yes, please. Yeah.
I mean, remdesivir, as you said, it's through a roller coaster ride. I would say remdesivir is in search of a disease to treat. I don't think we should be actually treating using patients with pregnancy. Remdesivir is out of question. It has very little and very, very different evidence anyways for it. So yeah, I agree.
Right. Non-pregnant patients also wonder about it. So we agree, and I mean your point is well taken, Dr. Rahul and Dr. Lupa, about its role. No, there's no role of this in pregnant patients who are having moderate to severe diseases. So next, coming to the monoclonal antibody, there are already a couple of questions about this from the audience. So I would like to ask Dr. Deepak about it. Like, would you like to give a monoclonal antibody to a patient who is moderately? This patient may be on some oxygen, but some patients who are already, suppose they have come to the emergency department and probably requiring just 1 or 2 liters of oxygen. What would be your approach to use of monoclonal antibody in these populations? I think, sir, is Dr. Deepak.
Yeah. I'm just sorry. I was stuck up something. So we were discussing
about monoclonal antibody, sir. If suppose you have to consider giving monoclonal antibody to a pregnant lady who is just requiring maybe 1 or 2 liters of oxygen, in general, would you consider this in pregnant patient?
It's a difficult question. Practically, I don't have got any experience using monoclonal antibody or such type of drugs in a pregnant lady. So it will not be very appropriate to answer this question.
Dr. Govind, can I add?
Yeah, please. Why not?
So this lady is definitely not a candidate for giving monoclonal antibody, but the pregnant patient are definitely at high risk, and as per recommendation, if they are like in early phase when lung involvement is not there, oxygen requirement is not there up to 5 days, there is no harm. In fact, they should be considered early for giving monoclonal antibody, but this patient is not a candidate. This might take. If George, Sunil, Dr. Joshi wants to add something.
Dr. Ranjan, would you like to add anything? Dr. Ranjan Joshi?
The stance we have taken is depending on which monoclonal antibodies you are going to use. If you are thinking about resin co, then it's moderate to severe disease with seronegative patients. That's what you'll use. But don't give in seropositive pregnant patients. Whereas I think the next discussion you are having in tocilizumab, so we'll talk about that. But sarilumab is not recommended to pregnant patients because the safety profile has not been established yet. So it's very conflicting evidence all around with pregnant patients, and it's more of generalization from the results of normal adults.
Right. So as of now, I think there is no safety profile is not decided, and it is not encouraged or not be a prompt approach or prudent approach to administer this antibody cocktail in pregnant patients. Dr. George, you are going to say something, please.
Well, as they already mentioned, then normally we will recommend the use of monoclonal antibodies in patients with mild symptoms, but not in those patients where we are already escalating the use of oxygen.
Right. So we'll move on to the next, another, very common.
So the key point is that a patient need oxygen, monoclonal antibodies out of question. A safety profile of what Dr. Joshi is that not established, but the cocktail, which is now prevalent in market because they are saying, so that has to be weighted, that we have to consider.
Thank you, Dr.
At the moment, it's not allowed to give pregnant ladies a monoclonal antibody cocktail, casirivimab and nivolumab.
Cocktail can be given. That cocktail we have used, Rahul, and it has
can be given as an off-label indication. The trial which was published had no pregnant ladies in it. The safety label profile is not done. But I completely agree with Dr. Mishra that we victimize a lady just because she's pregnant. We should be able to, again, the whole principle is to save the mother. So we should be able to give that.
Unfortunately, Rahul, problem is that all the pregnant patients are out of the trial for all trial. So unfortunately, that you have to just have experience. But so far, it looks that the current available cocktail, that is has not caused any harm, whatever we have used.
Correct.
True. So I think we all are in the same panel that we understand that it has no safety profile officially has not been declared, and according to the cases, it has to be customized according to the patient's conditions. And considering this lady who is now requiring around 4 liters of oxygen, probably will stay away from or refrain from administering monoclonal antibody. Now, moving on to another most very commonly talked about medicine or immunomodulator for COVID-19 cases, about role of tocilizumab. So, Dr. Rahul, would you like to share your opinion on, would you like to give or consider giving this drug to this pregnant lady who is 28 weeks and 4 liters oxygen?
I just forgot how many days was she?
28 weeks and 4
Sorry?
liters oxygen, 28 weeks.
No, how many days of illness? How many days she been on oxygen for? 2 days?
She had 6 days of fever and mild cough for 4 days.
Yeah, look, in the early days, I would give it to her. She's a high risk candidate. Having said that, I've not used a single tocilizumab since last September. I've got very different views for using tocilizumab. But for such patients, I am not saying I will never use tocilizumab, but for such patients, it's actually useful to give tocilizumab. It is definitely all right to give it at the moment, because if you can halt her progress, that would be okay. Tocilizumab or the monoclonal antibody, they are all monoclonal antibodies. The safety profile is the one which has to be studied, and tocilizumab probably had some safety profile study as compared to the other monoclonal antibodies.
So we'd again also agree not to administer this immunomodulator to this pregnant patient who is at this juncture of 28 weeks and on moderate oxygen requirement. Regarding advocating prone position for these patients to enhance their oxygenation status, what would be your approach, Dr. Ranjan Joshi, please?
I think we have discussed a lot, and Dr. Pandit touched about a lot on the prone positioning already. But right. I just mentioned the position that we take, and it's all based on our vast experience during H1N1 pandemic, to be honest. And as he mentioned, and I completely agree with that, towards the late pregnancy, it's a nightmare to do prone positioning in pregnant patients. And what we always recommend is consider prone positioning if you're doing it for 12 hours a day and in mechanical ventilated patient, if you have got a refractory hypoxemia despite optimizing everything. But you should take all the precautions to avoid the abdominal compression, as you will do with appropriate fetal monitoring. But as Dr. Pandit also mentioned, I agree that whenever possible, if you're planning on prone positioning, you better plan for your delivery, particularly towards the late pregnancy, and then it becomes a lot easier for you to prone in the postpartum period rather than late antepartum period. And the physiological changes was the question one asked. The biggest physiological changes that you see is the redistribution of the transpulmonary gradient, and that's how you re-recruit all the lungs, which is supposed to collapse and increase the VQ mismatch. And that's how it works better. And we know that from PRO-SEVA trial, particular trials and research has not been done in specific to pregnant patient, but that will be an appropriate generalization of that results towards pregnancy. And we have accumulated quite a bit of experience starting from H1N1 pandemic to other patients.
Right. So prone is a bit difficult at this point of 28 weeks, but I think definitely we can advocate a lateral position in these patients with that oxygen status. That should be safe in these patients. Now,
yeah, when you do lateral positioning, one thing I would like to point out, Samili, that when you're doing right lateral, that can be tricky with the aortocaval compression. So left lateral, you are safe. Right lateral, be careful, particularly with the fetal distress. And you know that with pregnant patient with COVID-19, there is incidence of increased fetal distress. We'll talk about that later.
Yeah, that's the one I wanted to highlight actually. So left lateral is the one position that we should be advocating or advising these patients instead of, for all other normal pregnant patients where you say right and left alternately. But this is a subpopulation of patients where you must, if you're going for lateral, left lateral is the best recommended one. Next,
Samili, just to add a thought, just to add to, in fact, not thought, even full prone with appropriate support, particularly you need a lot of support over chest and you need more people to support and decompress, put a lot of support over thigh and chest, but still full proning with adequate gadgets is possible and has been done. But when you reach to that stage, you simultaneously plan delivery of the fetus as well, because if you don't do that, it will be very, very difficult. So it is not like absolute no for prone position. You need more gadgets. You need more people. You need a vigilant obstetrician to deliver a fetus quickly as soon as possible. But you still can be, because as I said, that if hypoxemia is killing the mother, you have to improve oxygenation at any cost, and even at the cost of baby. So that thing should be kept in mind, that prone position is not contraindicated. Only thing, the procedure is tricky. You need more people, more gadgets to achieve it.
Right. So it's a relative contraindication. Obviously, logistically very different at 7 months of pregnancy with a full tummy, and there'll be, body mass must be increased. That is some kind of weight gain is there. But logistically, yes. So you should try to deliver the baby as soon as possible. We'll discuss that in the next few minutes. So what about the venous thromboprophylaxis? Would you like to use heparin, and which form and how long? Professor George Hidalgo, please, your opinion.
Yes, well, the same thing. I believe we need to individualize each patient, and of course, in pregnancy we can use either low molecular weight heparin, or we can use also regular heparin, and also much is going to depend as well in talking in general. If we are going to plan this patient to take it for C-section or for any procedure, that probably is going to be safer for us to put the patients on regular heparin, because we are going to be able to control better. That's and also based on what are the medical background, if this patient have any additional risk factors. The pregnancy itself is already a predisposition for clotting, plus the additional factors for the COVID-19. And if the patient have an additional background of immunological condition that can predispose, mean that we will need to consider on the individual basis, and also the different markers we use to guide us as whole, if we are going to use as a prophylaxis as well as full anticoagulation.
Right. And how long would you like to continue? Like, suppose this patient was not going for delivery of the fetus because she is on 4 liter and she is maintaining on that. So till the point of final delivery, whenever it is scheduled, would you like to consider that, or would you give it for a specified period and then stop?
Well, as soon as the patient is already mobile, then probably we can use it for an additional 1 week or 2, just for prophylaxis and for prevention after the delivery.
Right. So, Dr. Rahul, do you agree on that, or do you have any viewpoints?
I agree. All patients should receive a venous prophylaxis unless contraindicated, and pregnancy is a high risk. I justify that. And I also say that whether I would give it for the patient to be on discharge or not, I would probably not do that. But while they're in the hospital, I would continue the thromboprophylaxis, which is low molecular weight heparin.
Right.
I would like to add a sentence.
True. Hello?
Yes. Yes. I would like to add a sentence.
I will come back to you, sir. Can you come back to you, sir, please? Yeah.
Okay.
We will have a set of questions from all others at the end. So please, in the interest of time, we would like to move with the role of ivermectin, if any, in this kind of patients, because there has been a controversy, especially in the first wave. We had a lot of debate about using this ivermectin because it was very cheap, cost effective, and especially in low and middle income countries. And thereafter, a lot of controversies, it went into oblivion and has been first placed and then thrown out of many guidelines. So what about ivermectin? Would you like to use it any at all? Not in these cases, but if in suppose a mild asymptomatic pregnant ladies, would you like to use ivermectin? Dr. Lopa or anyone else, would you like to comment? Welcome.
Yes, I want to say something, because in Bangladesh, actually, there was lots of studies, and at the beginning of the COVID from the first wave, actually, we used a lot of ivermectin, and actually what drug worked, we don't know. But at that time, we found that yes, ivermectin is working well. But nowadays, it's totally removed from drug list in our government and society guidelines also. And you all know that from WHO also. But and now it's removed from all treatment protocols. And yes, it is contraindicated to use during pregnancy because of the potential teratogenicity and risk to the fetus. So we will definitely not use ivermectin, at least.
Thank you, Dr. Lopa, for clarifying that. So now we may moved on to next another case, which as I was actually affected with the severe COVID-19 illness. I'll just, this is a real case which was treated in our hospital. So she was a 31 years lady who was 7 months pregnant. This is her second pregnancy, and she has a live child around 5-year-old. She was also diagnosed with gestational diabetes a couple of weeks ago. Now she presented to the emergency department with chief complaints of dry cough for 11 days and breathlessness for 1 day. She tested for positive with the COVID-19 antigen around 4 days ago. Now, on arrival in the emergency department, she was dyspneic, for which non-invasive ventilation was instituted, and the baseline investigations were sent and an obstetric consultation was sought for. And the patient was immediately shifted to the COVID ICU for further management. So now she was conscious and oriented when she arrived in the ICU. Her blood pressure was good, heart rate was also good, but saturation was quite low. It was around 92% on NIV when she arrived in ICU. Maybe during the process of transport, she required more FiO2, and respiratory rate was on the higher side, though, and she was in actually moderate stress. Now NIV was connected, and after a few hours, we could win her down to 70% of oxygen. IV fluid was started, and antibiotic covers were given her long history of this cough and the time she spent at home. She was started on Dexona, and right and left lateral position was advised for every 2 hours, because she was, we could not obviously prone her. So my question will be to Dr. Hidalgo. Can you quickly summarize what all drugs can you use or can you give to this lady?
Yes, well, we already discussed some of the main drugs, no, and I probably in this particular case, I will probably definitely consider the use of the tocilizumab for this patient. Also, the other important is we will need to probably start her on thromboprophylaxis immediately, no?
Right. Okay. So now she is already at 28 weeks, and she has having the severe illness. She is almost on the 70 to 80% of FiO2, so in respiratory failure. So this is some case we definitely consider for termination of the pregnancy. So if you're planning for delivery of these patients, how will you proceed with the plan? If Dr. Deepak or Dr. Rajesh, anyone can take this question.
Yeah, so delivery is like we cannot induce the labor in this patient because patient is brink of respiratory problems and severe ARDS. So the only choice which is left is probably the cesarean section.
Right.
Is my take on.
So we actually had to, as Dr. Rahul mentioned or pointed that, we have to actually engage in a lot of discussions with the obstetrician and to convince them that this patient should be taken for emergency cesarean section and delivery of the fetus to give her any chance of life if at all she has. But I think this is a general scenario that we confront with, that many of the surgeons or obstetricians have a fear that of dealing with this COVID-19 positive patients during the process of delivery, and then are kind of trying to avoid it as much as possible. But I think that remains the crux, that for these kind of patients who are beyond 28 weeks or around that time, delivery of the fetus is the best way to give a chance to the mother to live thereafter and to institute further supportive managements.
Dr. It's actually important to have a controlled delivery of the child. And I agree with Dr. Deepak that most of the time it would be better to actually do a cesarean section rather than inducing labor, because their respiratory mechanics have gone down so much that you will not be able to sustain labor and then a delivery through a vagina. So
yeah, I think that is absolutely right. It's absolutely out of questions to try even any way to induce delivery in these cases, because they are struggling already. They are in respiratory failure on high level of non-invasive ventilation therapy. So they are definitely not suitable for induction. Rather, we should straight away go for cesarean sections. So now this patient was planned for an elective cesarean sections in the COVID operation theater. So what kind of anesthesia will you prefer for this kind of case? Because this was something, a real scenario. We had to have a engaging discussion with the anesthetist to decide the kind of anesthesia for these patients. I would like to ask Dr. Lupa, if you're having to plan or convince your anesthesia colleague for this matter, what kind of anesthesia would you prefer?
Generally, a neuroaxial block like we use the spinal anesthesia is considered in C-section operation. But in this case, as the lady is dyspneic and in borderline hemodynamics, already she has put on NIV and support, and she's requiring high flow oxygen. So prudent would be take control of the airway first, and first resuscitate the patient and stabilize, and from the hemodynamics, oxygenation, ventilation, and all her acid-base equilibrium, then we can proceed actually to GA, because this is a very critical patient, I think, and for cesarean section to delivery of the fetus. So my choice of anesthesia for this patient would be general anesthesia.
Yeah, thank you very much. I think that was the right choice, as you nicely and short narrated all the points in favor of general anesthesia over regional block in these patients. And actually, this patient was given general anesthesia, and during that process, she actually crashed. But however, the obstetric surgeon was good enough to rapidly deliver the baby. The baby was put into neonatal ICU, of course, and the mother was hooked onto the ventilator and brought to ICU with some support of.
Yes, and this patient will require vasopressors also, because her BP is also low.
Yeah, she after she crashed, especially in the intensive care unit, because she was taken to theater on the second day, and for a variety of reasons, we had to do it on emergency in the middle, because consent was not obtained from the family. They were not, they were also took time to decide if they should go for this emergency CS or wait for longer. But after we convinced that life of the mother is precious and she'll not leave, if the way she is going, things might go downhill. And they gave consent actually in the middle of the night, and then she was taken off for the cesarean sections. However, the baby did survive and was kept in the neonatal ICU. But she crashed and she came to ICU on the ventilator and low dose of vasopressors, which were subsequently actually managed well. Now, I would like to know about.
Can I just add one more thing, Dr. Shamini?
Yeah.
So, in a couple of patients in the last 10 years, we actually delivered the patient the C-section in the ICU on the ICU bed. So you need to talk again. It's a bargaining, because sometimes even with 100% FiO2, they are very difficult to even ship to the theater. So you need to talk to the gynecologist, obstetrician, and they will do it once in a while. This is not something which you would do all the time, but somebody who is very, very brittle to be even shifted to theater would arrest on the way from ICU to theater. We've actually done that as well. So it's not something which cannot be done at all. So we've got all the options available, which have to be thought as out of the box solutions.
Right. Yeah, it's both agents would actually arranging delivery in the intensive care unit, especially adult intensive care unit, is in itself is a challenge, because you have to have the pediatric and the neonatal team ready by the side, because we are expecting a preterm baby, and at the same time you need to have all the the best of the aseptic service arrangements inside the intensive care unit. So I agree that if it's best can be done by the bedside, that is good. But if not, whatever possible under circumstances should be tried. Now, I would like to understand from Dr. Ranjan Joshi, what are the general fetal complications that this babies confront with when they are born from the mothers who are affected with COVID-19 illness?
Well, that's a very fascinating question. Actually, I'm sure the obstetrician colleagues and some of the pediatrician neonatologists who are there must be willing to know, and what evidences we have got and what data we have got on this regard. Look, currently there is not enough data to support two things. One is whether the correlation between the risk of miscarriage and the COVID-19, and whether the virus is teratogen. Okay, so these two we don't know yet, and we will wait for some more data around it. This third thing is a interesting and a conflicting topic, rather, whether there is a vertical transmission of COVID-19 to the neonates. Most of the reports which has come out, and most of the tests we have done in our neonates who are delivered from COVID-19 mother, if you test them, they are negative. Even we have tested their cord blood, even we have tested their placenta, even we have tested their chorioamniotic interface swab. everything has been negative. Whereas some centers have reported that the cord blood is positive, but the throat swab is negative. So it's pretty conflicting. So now we tend to believe that there is no vertical transmission. Whereas on one study where they have reported that the immunoglobulin M level in the fetus is high. And as you know, immunoglobulin M is pretty big. So it cannot be transmitted from mom to child. So when the immunoglobulin M level is high in fetus, you expect that the primary infection has happened. So there is some kind of belief and a signal that vertical transmission does happen, and that needs to be actually researched, and hopefully we'll get some more data. About the fetal complications, when the mom has COVID-19 in the first and second trimester, now our practice is to do with more frequent ultrasound of the fetus to see their growth, how it is happening, or any other teratogenic or any fetal abnormality that we can detect. So far, all the data has been reported, hasn't done any fetal abnormalities related to COVID-19. Preterm babies are very common. As you said, a 28 weeks baby that you deliver, that's a preterm delivery. Premature rupture of membrane has been reported. A lot of centers have reported intrauterine fetal death as well. Intrauterine fetal distress is the most common thing that you will see. And the reason I will try to explain is that whenever you take the placenta out and examine under the microscope, what you see is that there is vascular abnormalities and there are a lot of intravillous thrombus in the placenta. So there is no surprise there that there is increased fetal hypoxia and distress in this kind of mom. Then what we see, the neonates, which they come out, once they come out, there is some degree of fever that lasts. Some of the abdominal complications we have seen, like nausea, abdominal distension, some degree of GI bleeding, but there is no evidence of necrotizing enterocolitis or anything like that. Then second trimester abortion is being reported now as well of late. There are some DIC in neonates they are reporting, but Apgar score so far, all the children that we have delivered has been pretty good. But obviously, if there is a compromise in the oxygenation of the mother, the Apgar score can be low as well. And some of these children also are developing respiratory distress. Some are developing pneumonia, transient tachypnea of the newborn, and sometimes pneumothorax in one kid we saw, and we had to drain that. So a lot of things we are learning, and lot might not be just related to COVID-19, but a lot of data still needs to be seen to conclusively tell that COVID-19 has got this kind of fetal implications.
Thank you, Dr. Ranjan. So that was quite summative. And now this lady came back to ICU. She was on high ventilator support. Next day, her total leukocyte counts increased and D-dimer also increased. It was in the ranges of 1.2. It almost jumped to 10.2. Now she's on high FR2 and high PEEP. We have discussed about our principles of pruning, I think. Now it's easier, I think, after that she has delivered. We could prune her. So now continuing story of this patients after 3 sessions of pruning, her oxygenation status started improving. She did contract a ventilator-associated pneumonia, and the cultures showed multi-drug resistant Klebsiella pneumoniae, which was treated according to the culture sensitivity report, and she did respond to that. She was started on heparin infusions as the D-dimer levels were quite gone high. She was tracheostomized after she tested negative almost around 11 or day 12. She was tracheostomized. She was decannulated and was successfully discharged with 2 liters of oxygen. So now, as we know that COVID-19 can literally affect any system, starting from head to toe. Now, what do you think? Like, does COVID-19 worsen other comorbid states like this peripartum cardiomyopathy or the preeclampsia or fatty liver, etc., that we normally see in other patients? It's an open question. Anyone can take it. Dr. Rahul, or
difficult to say, but I would say that COVID always gives you a googly, and there is no reason not to believe that you may actually have a worsening cardiomyopathy or liver enzymes going up in fatty liver. I don't know whether it actually makes any difference to the preeclampsia, because the process may be very difficult to actually comprehend and correlate. But yes, COVID affects everything from head to toe, any organ. So it probably nothing to do with pregnancy. It could happen to any non-pregnant person as well. So yeah, COVID can actually worsen the pre-existing diseases. No doubt about that.
Yeah, given it's actually a role in affecting the myocardium, causing myocarditis per se, or even affecting primarily the liver, it might worsen those patients who be having underlying cardiomyopathies or liver-related issues.
Possible.
So next we move on to a few of the controversies that have been many times put to us during this period of 1.5 years of this COVID pandemic regarding institution of ECMO if in a patient who has been refractory hypoxic and pregnant at the same time, pre-delivery. So it's an open question. Anyone can. Dr.
What I
George?
can do
when it comes to the decision to put a patient in a pre-delivery situation in ECMO is very difficult, no? Because we know that we already reached the refractarity of the either ERDS, and then of course that means that we need to take this patient for a delivery, and after that probably we need to consider the possibility of ECMO. No? I think so that should be my take on that. No, this is a very difficult position at that point to put the patient in ECMO before delivery. No?
Yeah, Dr. Ranjan Joshi, do you have any?
Yeah, look, we haven't had any. I was fascinated to listen to Dr. Pandit, his experience with ECMO in COVID-19, which he had put already 2 patients. One was prepartum, I think, as he said. But I can just share our all in general experience with pregnant patients. Obviously, it's a different ball game when it's pregnant patient. And pregnant patient with hyperinflammation, I think Dr. Pandit will know that establishing that amount of blood flow is a nightmare. So it should be done, in my view, in a very experienced center who do it regularly first. Second, it should be referred early. There is no point in ventilating and plugging the lungs for 10, 20, 15 days or 3 weeks on establishing all multi-organ failure, then referring the patient. So that, as you know, the outcome is not that great. Delivery of the baby prior to ECMO to enhance the maternal resuscitation and to decrease the metabolic demand so that you can have a good ECMO run should be considered. And the key consideration in relation to pregnant patient, I will always say, I will have a team of obstetrician, the intensivist involved, have a very thorough discussion with the family and taking into consideration the gestational age, the fetal viability, the fetal well-being, and the risk and the benefits of the mother and the baby. So it's a case-by-case basis. It's a difficult one, and it should be done in an experience center, and it needs to be done early rather than leaving it too late.
True. So I think the dictum remains do it early rather than late if you're keen to save the life of the mother, and the family is sometimes very pressing and for this matter. So the clear message should be early for the best of outcomes. So next we move on to vaccination in pregnancies. Regarding the incidences of that have been when we started having this vaccines started from Europe and United States, a lot of discussion about vaccine-induced thrombosis or thrombocytopenias across this world. A lot of controversies were particularly regarding a few kinds of vaccines or the brands of vaccine that were used. So any opinion on that, Dr. Deepak or Dr. George?
Probably Dr. George can answer better. I don't have got any experience on this.
What we are seeing in our side, specifically with the Johnson & Johnson and the Astra, we will see in a lot of patients with problems with clotting, with clots. No, I mean that is something that of course, one more time in the pregnant population is the data is growing. No, we don't, but in overall in the general population, that is we're seeing with this particular two types of vaccines. No?
Right. So any experience of Dr. Rahul? Would you like to add?
We should be very clear. Pregnancy vaccination has to be done. No question about that. WIT is a very difficult diagnosis to make. We see all the time patients coming in with low platelets and clotting problems, and we all tend to link it to the vaccine which they've received. I recently reviewed the literature because as part of a committee which looks after organ donation for the Roto and the Soto for Maharashtra region and the states. There was this problem where it was actually one of the possibilities which were talked about in patients who became organ donors. And to diagnose that clinically, there are only two ways: either do a PF4 antibody, or you do a D-dimer and see if the D-dimer is 4 or 5 times elevated. This is where practically we can do in India right now. There's a very good document which has come out by the NHS just last week, which talks all about it, and I would recommend everybody to have a good read. I can put it on the group, Dr. Sharmili, if you want to, because I just reviewed that 2 or 3 days ago. I don't see any reason why we should be worried about WIT and pregnancy vaccination. We should just promote vaccination in pregnancy as well as in breastfeeding, and just see how it goes, because I think the risk versus benefit ratio is heavily on the side of benefit than the risk.
True. And I think this vaccine-induced thrombosis or thrombocytopenia we've just talked about is mostly an idiosyncratic reactions, and it's not really related to a particular brand of vaccine. So this has been emphasized or discussed sometimes, but I think there is more or less there is consensus now that vaccination, COVID vaccination, can be safely done in pregnant patients. Now, regarding there's also been controversy or queries about breastfeeding and vaccinations. So, how safe is vaccinating a lady who has been breastfeeding? Dr. Lopa, would you like to share your opinion on that?
Yeah, actually, vaccination is ongoing in Bangladesh very successfully. And what we are doing now from the government protocol is not, there is no protocol actually about the vaccination, but from the Society of Obs and Gynae, they have ensured that, yes, you can vaccinate the pregnant ladies, but after first trimester, after 3 months. So we are only just because of there are not the type of data or studies right now. And what happened in Bangladesh, some pregnant women are also have taken vaccination from in the first trimester also. But I think now we are using it very frequently, but after the first trimester.
But lactation.
Oh, okay. Lactation, yes, I think I missed it. The lactation, yes, they are giving, we are giving here in lactation also.
Right. So,
yeah, Sharmili, can I come in?
Hello.
Yeah.
Good. Sorry.
Can I come in? Yeah, Professor Panda here.
Sir, I will just come back to you. Okay. Just few minutes, please. We'll just come back to you.
Yeah.
So, but we'll just conclude this and we'll take all questions from all the audiences and all other panelists.
Sure.
So, regarding the small data on the transmission of immunity or immunoglobulins from mother to fetus, I think Dr. Ranjan Joshi has already highlighted that point. And the last one, important question is the neonate really protected by maternal antibodies? If suppose the mother has had the disease and the mother has recovered and the child has been delivered thereafter, is the neonate really protected by those antibodies?
Should I go first or Dr. Hidalgo is going fast?
Yeah. You decide. Dr.
All right, let me start. This is really a fascinating question, to be honest. This is fantastic. We all need to understand here that an important aspect of the maternal response to COVID-19 infection is the rapid resolution of the infection by neutralizing the immune response and transfer of that immunity to the newborn. And the maternal immune system plays a very unique role in pregnancy since the newborn depends on that active transfer of that maternal immunoglobulin G across placenta for its protection against the pathogens, right? So what we have seen is that recent data has shown, initial data came in, that the transfer of that immunoglobulin G from mother to the fetus was not that much as it used to happen in COVID-19 case as compared to any normal women. And the reason for that, they found out with the theory that is an altered glycosylation profile, which actually preventing those immunoglobulin G transfer to the neonates. But later on, the Israeli study which came in and where they studied 950 plus patients, where they compared the mothers who had been vaccinated and the mothers who had been COVID infected, and took the cord blood and took the immunoglobulin G and G titer compared with the maternal immunoglobulin G titer. What they have noticed is that if the mother has been infected before 30 weeks, the immunoglobulin G titer in the neonates is very good at a level which can protect them. Whereas if the mother is infected after 30 weeks, then the immunoglobulin G titer is less. So it basically depends on the gestational age of the mother. The second thing is vaccination, which is giving us the antibodies against the proteins like S protein or S1, S2, RBD, or N, that also get transferred through the cord blood. But again, if it is given a bit early, it gets transferred pretty well. If it's given a bit late, it's the lag time through the placenta which plays a significant role. And here comes the lactation as well. That same immunoglobulin level has been found in a pretty significant amount through the breast milk. And that also adds on an extra layer of protection to the neonates. So that's why the perplexed theory of neonates being less infected as compared to their group, like a bit older pediatric population, is probably one of the reasons that the immunoglobulin transfer through the mother, either through the vaccination or being infected, is working. That's one of the reasons, apart from many others, which we don't understand yet. And this is one of the reasons also that we should promote vaccination for mother to protect the neonate.
George, would you like to add anything?
Sorry, I'm in a call right now. Sorry.
Sorry. Okay. Yeah, Dr. Professor Panda, Dr. Jain Panda wanted to comment something. So please add. Professor Jain Panda.
I wanted to come in for that vaccination issue. I have a couple of cases in pregnancy and lactation who have been vaccinated and developed few issues. As rightly pointed out, the thromboembolic issues. Actually, we know that the disease itself is having some thromboinflammatory illness, and especially the Covishield has resulted in very rarely cases with even infarction, cerebral infarction, and peripheral thromboembolic phenomena. So in such a situation, pregnancy is also a prothrombotic state. We know the chances of coagulability deteriorate. So we have a couple of cases reported in SCB and in Odisha related to thromboembolic complications in patients post-vaccination with Covishield. So though it's declared safe and now guideline tells vaccination for pregnancy and lactation, we should keep our mind open for such complications and observe the pregnant lady or lactating lady if there is a related complaint thereof.
Yeah, thank you, Dr. Professor Panda, for adding those comments and sharing your experiences. I would request Dr. Professor Prasanna Mishra, please put forth your comments. Actually, sir was trying to add some comments during the discussions. So are you there? Can you hear me?
Yeah, I hear you.
Sir,
At
Sir
that
Millie,
time,
Sir Millie,
I
Sir
wanted to
Millie?
comment. Yeah, okay. At that time, I wanted to comment in the sense that regarding that heparin, these days, obstetricians, if they have any problem with a pregnant lady, they start giving heparin even from the so early, even continue till the delivery time. So using heparin in COVID patients can continue till even delivery. That's what I wanted to tell.
Sir Millie,
Yes, yes. Yes, Dr. Mishra.
your slide is done or still you have some discussion?
No, I have the summary slides and so you would like to add your opinions, please.
No, nothing.
I think we have already come to the end of
So I'm sending you what you said. I'm sending to your mail because I sent one more mail.
Yeah, we are just going to discuss the summary points. Yes.
No, I'm sending you the key point. Just open. Just a moment. I sent previous one. Open this one.
So I think it was a very fruitful and engaging discussions regarding the challenges and the unique learnings from COVID-19 in pregnancy patients. So summarizing that dexamethasone or hydrocortisone are preferred, given that if you're planning early delivery for these patients, especially keeping in mind regarding the fetal lung maturity, and it needs to be thoroughly assessed and planned for early delivery if respiratory status starts worsening, because the key point remains that the mother's life is more important, and the mother life has to be saved. And if you're planning proning at all, prone them early. ECMO can be planned as necessary. It has to be a teamwork in between the neonatologists, pediatricians, obstetricians, and the intensive care team. Vaccination is absolutely safe during both pregnancy and during breastfeeding period. Sorry. So I think there are a lot of questions. I stopped sharing my screen now. There are a couple of questions in the chat box. I'd like to take that.
You can see the whatever final discussion he had. I sent you slides. You can open it and discuss.
I think we are having lectures, so
yes.
Why not we finish off lectures, then we can summarize everything.
Yeah.
I think there was a question, just like one question, because I'd like to, the eminent panelists are there. One question regarding a patient who had cardiac arrest following spinal anesthesia in a patient who had recently recovered from COVID-19. So any specific points along with, cardiac arrest in a pregnant patient has to be handled as we routinely do, but in the context who has recovered from COVID-19 illness.
Better to avoid spinal anesthesia.
The patient was recovered actually. What recovered? She's not ill. She is delivering and she had given a final anesthesia. Any points would you like to add, Dr. Mishra or Dr. Rahul Pandit?
I don't think so. I think you just treat that as normal cardiac arrest in a pregnant lady, and you go ahead.
These patients are prone to have a shock and cardiac arrest, particularly post during full-term pregnancy because of IBC compression. So if at all you have done it, you keep a close watch. That's one thing which is missed very commonly. If you have done under spinal anesthesia, prefer to avoid. If you have given, be watchful for probable cardiac arrest.
So thank you very much, all the panelists, Dr. Professor George, Dr. Deepak, Dr. Lopa, and Dr. Ranjan Joshi, and Dr. Rajesh Chandra Mishra for adding and contributing and making it such a rich and fruitful session tonight. And thank you very much. I think we will proceed to the next sessions. And I'm happy to share that almost around 130 viewers who are watching us live now.
Dr. Shamil, take you, all of you. Okay, thank you very much.
Thank you very much, Dr. Rahul, for joining.
Thank you. Bye.
Thank you, Sir Millie. If you don't mind, I will also go and sleep. It's pretty late night for me.
Yeah.
So,
For those who joined late, Dr. Ranjan is from Adelaide, Australia, so he's lagging around. He's ahead of actually another 5 hours, so it's almost past midnight for him. So have a good night and
it's
take very much
1 o'clock now.
Such a short notice.
No, thank you so much. It is brilliant. Thank you. Have a good time. Thank you.
Thank you. The next session, I would like to invite Professor Dr. George Hidalgo for his talk on the global perspectives. And for that session to chair, I would like to invite Professor Dr. Jayant Panda. He is the HOD of Internal Medicine and Head of Critical Care at SV Medical College, Cuttack. He is very active academician and critical care expert, and has been an active participant of the state task force regarding COVID-19 management. And also we have Dr. Jyoti Narayan Sahu, if he is there around with us, please. And also Dr. Rajesh Mishra and Dr. Deepak Govind to chair the sessions. Over to you, Dr. George.
Thank you. And one more time, thank you for your kind invitation and to be part of this extraordinary session, and especially when we are talking about this particular group of population that is definitely really important. No? What I decided to do is we are going to share in a different perspective, and especially because despite of everything, when we believe that we are almost out of COVID, and we are facing with a different wave in our different countries. No, I mean that I will share this presentation about what is the lessons that we so far been learning as a leaders dealing with the COVID. No? I mean that the first of all, I just want to say that I don't have any conflicts of interests, nothing to disclose. Just basically the extraordinary friendship that we have with you guys, and I really appreciate. And then of course this is the different phases that we have in the left side over the pandemic, and the different stresses that we all in our different units and different countries have been faced over this duration of the pandemic. And of course, the 2020 will be remembered as one of the most significant global pandemic since the Spanish influenza. And as we know, the COVID is a challenge at global level for us leaders, since basically this coronavirus, they don't have any national boundaries, and it's been challenged at national and international levels for all of us, the people that are basically in the policy decisions in response to the pandemic, where definitely we need to comply with the government guidelines, support one each other all times as needed. And every one of us as leaders definitely have been bear a significant responsibility for others' health and well-being. No? I mean that not only the fact that we are heading the unit, but also is a strong responsibility, because we need to see and make sure that the people that work in our units also they are safe. I mean that as a leader, we at the beginning we essentially been very difficult, because with a significant uncertainty at the beginning of the pandemic that essentially was exacerbated with many other challenges associated with trying to make very rapid and adaptive response based on something that was completely new to all of us, and make and act this leadership in a different situation that we usually are accustomed to that. And of course, this type of exercises that we normally see in emergency sectors as well as the military levels, we knew that this COVID will presented with a different and unique challenges in terms of management, and especially to require to a large scale human behavior changes, adoption of insufficient collective benefits, that the benefit that wasn't warranted, and definitely this global pandemic put our health systems and basically we believe and also show the weakness on different aspects. We know that many people, of us, billions, were into lockdown, unable to visit each other, unable to go to work, unable to attend school, unable to meet in public areas. I mean, all this definitely was very confused, was very unclear, and definitely it confronted with an actual uncertainty and also the vulnerability of our human life. I mean that it's been definitely challenge. But in all of that, I think so. One of the things that we need to realize is that it came with some of the aspects that we need to remember, and as leaders, we need to definitely create this trust that been trying to work on as an individual expectation, and making sure that we are working based on the vulnerability of our the people that we are responsible for, and of course that over all this time we're trying to move with honesty, fair, based on the integrity principles. I mean that the importance of trust was very critical, I know, and also we've been seeing through the pandemic that we have a different phases with ability that we have now with the social media communication, the fact that they definitely have access to a lot of information, and then trying to deal with that, with the misinformation, trying to dealing with all those things that that we call it the infodemic or social media, that basically cause a disruption in the way we normally deal, and it in a way it trying to affect the direction and or leadership. But however, despite of everything, the scientific public health experts remain more trusted by all this type of misinformation. But in a sense, it creates a disruption in our daily practice, the way we traditional create the trust. This COVID-19 pandemic definitely demonstrate to us many things, and we will essentially grow as a leaders to all these different challenges. I mean that the trust definitely an important and a key foundation, that basically our relationship is oriented, and it could be situational, it could be authentic or servant leadership, and essentially we need to try to create this empathy with our people. We need to be logic, and also it can also help us to be authentic and trying to value this congruence with the different areas where we definitely are leading. Of course, one of the most important things is the preparedness and planning. We've been discussing through the whole morning the different challenge that we have in manage a patient, especially the pregnant patients, and definitely one of the preparations and the planifications is definitely a key. We remember that in the last 2 decades, we've been provided with glimpses into what we are experiencing now especially with the H5N1, the avian influenza in Hong Kong, the SARS, MERS, and Ebola, that in a way give us some elements to that we are now using during COVID-19 pandemic. No? It's important because we need to include all health professionals, researchers, managers, the industry, the different sectors to try to work together, no, and bring all these leaders in this times of uncertainty to try to pull all our efforts together and to try to create and have information from reliable sources. It's very important also that all we do needs to be supported with information and data, and sometimes it's difficult, but surveillance systems, including the testing, contact tracing, that are crucial to understand the pandemic. The clinical data collection within the health system is equally important, no? To try to understand the resources, the patterns of the disease, the different interventions that we need to do, and also at the end of the day, with only one objective, to try to provide our patients with the best outcomes. The international cooperation has been critical, and I believe what is happening today is an example of that, where we are have people from different areas, from different countries, with the only one intention to try to all of us put our best efforts again to offer our patients the best. No? The international information sharing, the global surveillance, and probably one of the most surveillance that basically most of us are consulting is the Johns Hopkins University. And essentially just an example, but what is critical is to be able that we can predict data modeling that can leverage this to provide us as a leaders with a range of different scenarios based on specific assumptions, based on of course transparent and accurate information, and of course that an increased emerging evidence, comprehensive nationals, and I believe the international cooperation, the fact that we are able to share our different information is critical to be able to face the pandemic in a better form. And this definitely the creating trust and through these different actions need to be happening in an adaptive and a coordinating form. We know that sometimes it's complex and unpredictable situation, but we need to, as a leaders, need to be able to adapt in a different levels, and we need to involve clinicians, researchers, trying to have an updated definitions to know exactly what is the course of the pandemic. As we know, especially the armamentarium and the way how we started the pandemic a year ago, and now we know that we have some more knowledge about how to deal with the pandemic, but of course, still a lot of things that we are still learning. We are still, of course, trying to do the different tracing applications, develop many other different strategies as how we are going to do as an individual, but also as a society, deal with the pandemic. You know? Of course, building trust is important, and we as a leaders need to make decisions and definitely provide a sense of control. We need to have this our local command centers and other different task-oriented leadership structures that are essentially critical in supporting the intelligence gathering and also the timely decision that we need to make. And probably one of the most important aspects is that we, as a leaders, we need to be and trying to remain connected with our people, with our communities through this process, trying to keep them informed. And also, one of the most important things is that we need to allow this two-way interaction with the frontline people, trying to decentralize leadership, and also to be able to work and develop different strategies that it will help us into the pandemic. And of course, we need to, one of the crucial aspects is to be able to create networks of relationships. And again, this today is an example of that. No? And I believe I want to congratulate the Indian society, because it's definitely, I see the different ability of networking and relationships that at the end of the day, it benefit all of us. No? But of course, you guys have been an example of and the ability to create these networks and to, at the end of the day, have a greater communication and an important coordination that we are all benefiting to create different strategies for our patients at all levels. No? And as a leaders, we need to be able to engage with our community through local groups to ensure that this definitely a local ownership, because I think so it's important that as a leader we have certain level of ownership and to be able to engage and to move with the appropriate intervention and acceptable decisions. No? Communication is critical, and also one of the important things is that we need to make sure, as at the beginning, that we also are coordinating different strategies to support the well-being of all the people that are around us, so the people that work with us, that we need to do a different planning for the staff and the community at all levels. No? Of course, that's definitely, as a leaders, mean that we need to act with responsibility and transparency, and also we need to be able to show accountability. And that is definitely some more aspects that are very critical as a leaders. No? And that's responsibility and transparency is critical, because of course the followers that trust in us as a leaders, they need to access a very objective information, be able to speak and ask questions, and also we need to be open and transparent in those important aspects. No? That include that we need to be accessible, available, open, and willing to answer questions, as well as to provide credible, up-to-date information to the different followers, no, the people that work with us. It's definitely right to say that the pandemic is definitely not a time to identify many things, but definitely we need to also at the same time we need to be able to go back with and trying to review what things we did, and also most important, what can be done to improve the outcome of the different actions. No? We need to be authentic, but all the time we need to try to do our leadership based on ethical values. That is important. No? We need to act with professionalism, ethically, and also to trying to face adversity. I believe that is definitely beyond that. We need to try to create this empathy among our people, with honesty, express the concerns that we have, and act with benevolence towards our followers and peers. And the pandemic is associated with response such as restriction of mobility, with uncertainty, anxiety, that definitely, as we've seen already, it paralyzed our community in different levels, and it's in certain way it also creates division. No? but we need to do that. We need to be able to create and sustain trusting relationships, and also as a leader, one of the most important things is that we need to be able to delegate responsibility in the sharing decision-making processes. Today, we just came together to try to see how we can try to prevent and to identify the coronavirus disease in pregnant women as is essential. We know that it's a vulnerable population, and of course, as we know, many of the clinical trials, this group is excluded, but the COVID-19 is being provided us with the possibility to create some more data with time. I mean that I just want to one more time, thanks for the kind invitation, and I just want to conclude that trust in leadership is needed for transformative collective action in times of uncertainty. Preparation and planning is critical, and of course, as a leaders, we need to adapt to ensure a coordinated response. We need to definitely be responsible, accountable, and our leadership is definitely a very dynamic process. With that, one more time, I want to congratulate the Indian society, and of course, I want to for all the efforts to trying to establish this incredible network of communication, and thank you one more time for your kind invitation. COVID-19, it continues to play out over the globe, and it's becoming clear that trust ultimately also requires leaders to offer hope and a credible vision to our lives for the future, and guide us as how to we are going to achieve that. Today is an example of that. Thank you one more time.
Thank you, Dr. George. Actually, this is the global scenario. What you have shared is more or less like our national scenario also, and all you told regarding the public health aspects and the people's perception and the suffering, and especially in a vulnerable population like pregnancy, the children, the elderly, and people with comorbidity are very challenging. In our institute, SCB Medical College, we have a unit completely dedicated for obstetrics care, and COVID-3 is a unit where only people are admitted in, so to say, the women all over the state of Odisha, and this is the eastern part of the Indian subcontinent, where we have treated more than 200 pregnant ladies by far and delivered the babies. So we have a very challenging experience in our institute. I think Professor Mahapatra will also share in his presentation the COVID-19 and pregnancy, the national scenario and challenges, and the global picture. What you gave is more or less like the situation in India also. I request Dr. Rajesh Mishra and Dr. Jyoti to give their comments.
No, I would like Dr. Mahapatra to listen. Dr. Deepak can say something, and then I like Dr. Mahapatra to say something, because a learned person like him, they would love to listen from him and his experience. Dr. Mahapatra.
Sure. No, I agree. We would love to listen to Dr. Mahapatra.
Yeah.
Thank you, Dr. George, for his very elaborative and summative experience of how the global scenario is, and how the global leadership matters in this time of crisis. Thank you very much once again for accepting our invite in a short notice. And with that, we proceed to the last talk of the session tonight. Dr. Professor Purna Chandra Mahapatra is a very familiar name in not only in Odisha, in the entire country. He has been the past president of Indian Society of Gynecologists and Obstetricians. Is a very popular clinician and one of the excellent surgeons that the country had ever had, and is an excellent speaker as well. So I'd like to hear from you, sir, about the obstetric viewpoints of COVID-19 patients that we have experienced in the last 1.5 years. Over to you, sir. And to chair the sessions, I would like to invite Professor Dr. Prasanna Kumar Mishra, who has been a very close ally and friend and philosopher for Dr. Purnachandra Mahapatra, and also Dr. Deepak Govind. Over to you, sir, Dr. Mahapatra.
Thank you,
Okay.
Sharmili. At the outset, I must congratulate you and the Society Orissa chapter for a very versatile and a dynamic aspect, particularly on obstetric point of view. Lots and lots of webinar is going on COVID and various aspects on the various different faculties of medicine. But I think today's webinar, I was just watching it for last couple of hours, and it was so interesting that I learned many things then to share you my knowledge on this COVID-19 for that. And at the outset, I must thank all of you and congratulate that you have been able to bring very, very dynamic people and experienced people to share their experiences for the last 2 hours or so. And my revered chairpersons, my elder brother, PK Misra, and all of you, I again welcome for that concluding remarks for that. Well, believe me, COVID, as we know, that COVID-19 till today, we are all doctors are treating COVID without knowing anything about it. I think the first phase and second phase, we have learnt in the second phase to some aspect, but till date, we do not know. Many things are not being detailed, revealed out, only on postulations, only on our own experiences, only from the lessons learnt. We are practicing both as in the ICU as well as outside also. The intensivists are very, very, I think lot of strain has been there for the last 1.5 years on the intensivist, and they are really puzzled about the different aspects of management of the COVID-19, and more so when they face a pregnant woman. I think that is a very big challenge to the intensivist, and which I am not in the part of that. I do not know much of that, and today, from your discussion, I could learn and gather information on many of the aspects which I do not know. But overall, COVID-19 is what? It is based on uncertainty and adversity till today. And whatever experience we have got, lessons learned, maybe that the RCTs, the studies, the different center, individual, and the majority of the collaborative studies, that will come out, and more information in the near future will get it on. Well, as far as obstetrician's point of view, I must say that way back in March, in last January 2020, last week of January 2020, 23rd January, the first report came that there are 3 pregnancy in COVID pregnant women in Wuhan. Later on, in March 24th, 9 cases was reported in Wuhan. Subsequently, over the last 1.5 years, we have crossed lakhs and lakhs, and documentation is still not proper, and we are not able to find out what is the exact figure of pregnancy which has been there. The most, I think, reliable and the most exemplified in the number, numerical values has been by the CDC. CDC has done an extensive work, and the researchers in the numbers, particularly in pregnancy and non-pregnant individual, and analyzed few of the data, where by October 2020, they have finalized about 23,560 cases and pregnant women, and analyzed how many of them are just asymptomatic, how many of them are symptomatic, how many of them have gone to the admission to the ICU, how many of them are on ventilator, and at last, what is the mortality and the maternal as well as the fetal mortality and the complications out of it. And out of all these, the questions on the obstetricians meant, I also thought when the COVID came out, what will be as a healthcare provider of women, and particularly in pregnancy, I'm concerned about it. First and foremost question I asked myself, whether this COVID infection will be more in males or in females. That's very important. Forget about pregnancy. But as we know previously, males are always if you find any health issues, males are the sufferers, and the mortality, if you find mortality, morbidity, everything, females are something a human species, both genetic wise and due to some other species, they are stronger than the men. That is no doubt about it. And I was sure at that time, I was confident that COVID, if you compare the gender issues where the males, females will be less exposed, less affected by the COVID and all that. When we come to the pregnancy, then my question comes whether the pregnancy is relatively, the pregnancy immunology is not being very clear. And therefore, whether in pregnancy, the chances of COVID infection is more or not, and they will be more affected by that. Now, regarding the COVID, we do not know, but regarding, we have some experience on the other viral infections like the flu, swine flu, the SARS infections, MERS infections, where it has been documented that the pregnant women are even not exposed more as compared to the non-pregnant, but if they suffer, the severity of the infections will be more and the mortality will be more. So that is a lesson which learned, we anticipated and replicated it to the COVID infection also, because the previous RNA virus infections, we have learned that it could be one of the possible, but we thought, and that is my question came, that whether the pregnant women are more prone to infection, if they are infected, whether the severity of symptoms, what is the percentage of asymptomatic versus symptomatic, if in symptoms, what is the more symptoms they are more common, which is being that, because in symptoms also we now find that there is a varieties of symptoms in COVID now which has been there, but in pregnant women there are limited to the fever is more. Number one is the fever, number two is the respiratory problem, and number three is some of the myalgia and the different aches in the bodies. These are the three main. Apart from it, the taste, the smell, the taste, the general vague disturbance and all that are not being very found in females as compared to the males, particularly in pregnancy. Now, the severity of the symptoms is very, very important, and what percentage of cases do go to the ICU and what is the death. I think you people have a better documentation about the death, but as far as the CDC criteria told, the death is not that much as compared to the other counterparts for that also. So that is a part which I think that this is reported, and maybe that in near future we can go more for that. About the risk to the mother, there have been a lot of studies which I can extrapolate and then tell that again the question comes whether it is affecting the first trimester, whether there is a risk of teratogenesis or there or not. I think a lot of studies have disproved this, that the teratogenesis is not seen, the incidence of abortions and miscarriages are not seen, but the incidence of preterm labor and preterm birth has been reported, that is accepted from everybody for that. And moreover, the incidence of cesarean section is more common, and more so, particularly when there is a hypoxia. Otherwise, normally in a positive, in a fever and all that, you just monitor the pregnancy. We monitor the pregnancy with the conventional biochemical as well as the biophysical methodology, with supplemented with the clinical correlation. We continue the pregnancy for the fetal survival as far as possible. But the problem arises when the patient is in ICU, the mother's condition is deteriorating, the hypoxia is there, whether that condition, the fetal hypoxia will be there, the IUGR will be there, and IUFD has been reported for that also. And increased incidence of cesarean section to save the baby is more often contemplated for that. Now, that is one, teratogenesis, abortion, preterm. The preterm labor is more common. And one of the very important question is a vertical transmission. We have thought that, yes, is there a possibility of vertical transmission? Till today, whatever research is there, we can confidently say that it is not yet proved that vertical transmission occurs from the mother to the child and all that. And although there are some immunoglobulin studies which have been demonstrated, but it is completely said that it can be isolated. It is not a vertical transmission. Rather, reinfection of the neonate could be one of the possibilities for that. And last but not the least, about the vaccination in pregnancy. Regarding the vaccination of pregnancy, we have really toiled before the government, particularly in India, government of India. I wrote several letters quoting several findings and all that long back after the first, in the late part of the first wave. Before the second wave also, we have toiled with the government and told that, yes, you allow the pregnancy and lactation because lots of proofs are there that vaccination is absolutely safe. And at last, the ICMR is the body which gave a concurrence that only the lactation they allowed it, but pregnancy is not. But on behalf of the society, the FOXI, and our personal behalf, repeated reminders and letters we have written to the government that at last the government has really agreed to give it in vaccination, particularly in pregnancy. It's safe because we have given a very important data from the Mayo's Clinic, from the RCOG data, from our CDC surveillance, and therefore vaccination we allowed that, yes, because this is what we know. There is no treatment for this COVID at that time. So only thing is that I only propose vaccination. There are two vaccines: social vaccine, medical vaccine. Social vaccine is a mask, and medical vaccine is either whatever vaccine is appropriate for that. For political reasons, they accept one vaccine, they reject another vaccine for that. But if available, make use of that. And strongly, I am in favor of that vaccination in pregnancy for that. But still in vaccination, again, whether the neonate is protected or not, that is yet to be evaluated for that. But as we learned from the previous vaccination of flu vaccines, we hope that this could also give a protection for the neonate for a couple of months. And therefore, in the mother and baby could be solved for that. So therefore, from the beginning till end, I think this is the nutshell of my viewpoint as an obstetrician regarding the COVID-19 situation. Maybe that we learn more. If we exchange our ideas amongst ourselves, I think we learn more. At that time, Sharmili, I must remind you, at that time, I personally talked to all the intensivists available in India, in Orissa, and under the stewardship of Professor P.K. Misra also. You try, have an exchange of ideas and find out what could be the mortality in general, as well as for the pregnant women for that. You have done a lot in the ICU, inside the ICU, at the cost of your own life, at the cost of your family. I must congratulate that. Not only you are involved in treatment, but this part about the teaching part, the updating part, and conducting this academic scenario, I will again have a special congratulations for you. Thank you very much.
Thank you, Professor Mahapatra, for your kind words and giving a picture of the COVID scenario and the obstetrics in India. Thank you very much. It's a really eye-opener what you have said, and it's an encouragement to the young people like Dr. Sharmili. Thank you very much, sir.
Thank you.
Thank you so much, sir. Actually, in fact, your words only keep us keep reminding me about doing such sessions dedicated to obstetric critical care. I would like to hear final words from Dr. Professor P.K. Mishra.
Yes, very nice talk. And from long time, Dr. Mahapatra used to say two vaccines, social vaccine and this vaccine. And I cannot forget that. And he emphasizes on that also today. And thank you, Dr. Mahapatra Purna. God bless you.
Thank you.
Thank you so much, sir, for sharing your experiences. One question, actually, I think we are getting some questions from the audience also regarding this patients, pregnant patients who are affected with COVID-19, and if they had gestational diabetes. Like, did you see Professor Jayant Panda? He's actually the specialist in diabetes, and he has managed thousands of cases in this COVID pandemic times. So I'd like to hear from you, sir. Like, did you think that patients who had COVID-19 and also gestational diabetes mellitus, was it a bit more difficult to control their diabetes compared to pregnant women with GDM who did not have COVID-19?
Sharmili, before Jayant, can I have an opinion on that?
Yes, please.
Yeah, sir. Welcome, sir.
Because the CDC, again, coming to this particular, the very vital questions you have raised it. CDC has defined about the prognosis of the case and pregnancy. Three important landmark point association has been associated with pregnancy. One is the age, elderly. Second is comorbidities like diabetes, gestational diabetes or hypertension. This is another area where their risk factors are there. And of course, the third is about the other obstetric manifestations and obstetric complications. These are the three main aspects where the risks are much more for that. So these are to be taken about it. And the last is about the obesity. So elderly age, obesity, comorbidities. These are the three main things which adds to the mortality and prognosis of the disease as per CDC. Yes, Jayant.
Yeah, very rightly spoken, sir. You have completed, and I congratulate you for touching upon every aspect, starting from vertical transmission, starting from vaccination and the management, every aspect you have touched. Regarding what Sharmili ma'am has asked, I'll tell one thing. We have seen many patients, especially the obstetric cases, more than 200 cases in our COVID-3. And personally, I have contacted more than 30 ladies with pregnancy. And we have lost 3 from them also. The most important challenge in such a situation that pregnancy, diabetes, and also controlling the other issues like the thromboinflammatory issues and as well as the diabetes related comorbid. We know that diabetes itself has many complications. Pregnancy itself has many issues. When COVID joins there, everything is complicated. And here I want to summarize, the blood glucose control is a real challenge. Pregnancy is a state of relative insulin resistance. And if the patient is a known diabetes or having issues related to gestational diabetes, the infusion pump is needed in all the cases we admitted to control the blood glucose. We prepared a insulin infusion and we gave a steady infusion of 1 to 2 ml per hour and monitored the blood glucose. Still, they needed 5 ml, 6 ml, 7 ml. And the blood glucose control is directly determining the outcome in the moderate to severe this COVID-19 positive obstetrics patients. So this is a very important issue, as Professor Mahapatra has already pointed out. If the lady is obese, if she is diabetic, if there are comorbidity like hypertension, heart disease, asthma, cancer, and again patient is COVID positive, the situation gets complicated. The prognosis becoming bad to worse, and you need to be extra careful in such a situation.
Thank you very much, Dr. Professor Ponda, for your inputs. So I think with that, any inputs from anyone that is welcome to discuss, or we are coming to the end of the webinar tonight. Any questions or any serious point, pertinent points anybody want to make? I cannot see any more questions in the chat box. I think more or less we have.
I want to bring an important point. Actually, pregnancy being a immunocompromised state also, those pregnant women vaccinated, it's not all over. We have to give a real thought regarding the 3rd dose, the booster dose. We have done an antibody assessment of around 78 pregnant women, and the antibody starting from a very high level, it has reached very low level in a span of 6 months. So many countries have started that, especially in pregnancy, the booster dose, 3rd dose vaccination of many vaccines. Though there is no clear-cut government guideline at present, we have to think of, we have to publish, and we have to see the antibody level and immunological status of the woman, especially in pregnancy, in relation to the booster dose.
Yeah, I think that's a very valid point you raised. And anyway, 3rd dose, it's already come to practice, and many parts of the globe they have started taking it, either officially or unofficially. I would like to know opinion of Dr. Rajesh Mishra or Dr. Ashit Hegde, if Dr. Hegde is still there with us, and Dr. Rajesh Mishra.
Regarding
3rd dose of COVID vaccine in pregnant people.
We are on learning curve. Maybe it will be needed, but I don't know the answer. But it is true that after some time, the antibody level is going down, drastically down. But as we know that COVID is not a typical humoral immunity, it's a more of the cellular immunity, and T-cell function is more important than the antibody level per se. So I'm not very sure about what will happen to 3rd dose, post-4th dose, a yearly dose. We are in learning curve. Theoretically, it makes a point, but I'm not right person to answer this because still things are going on about it.
Rajesh, the same opinion of mine is that it's really, I agree with you that it's just a presumption and assumption. And till time will say whether there is a thing. Second important thing I will try to point out, that it's a RNA virus. RNA virus mutations occur, changes in the species occurs. As we have learned, we are giving the swine flu vaccines for long years. And every 6 months, the company even if we give a trivalent or a quadrivalent vaccine, the pattern changes. They manufacture this after 6 months, that is discarded. The other vaccines, depending on the prevalence of the particular strain, the vaccine has to be also changed for that. That is also a big question mark where you find out for that.
Very important and valid point, sir. So thank you very much for all your so invaluable inputs and making this discussion so lively and engaging for all of us. And thank you again, all the international faculties. I think they are in different time zones and they are facing their time deadlines towards the end of, of the end of night or even morning, some of them. Thank you so much. Dr. Lopa, Dr. Professor George Hidalgo, and Dr. Ranjan Joshi has already taken leave from us. And I would like to request Dr. Deepak Govind for his concluding remarks before we move on to formally conclude.
So this obstetric-centric webinar was an eye-opener. Myself, who has got not much exposure of the obstetric in COVID, learned many things from you all. Thank you very much. And I feel that this type of specialty webinars are now need of time, because we have done many webinars for general aspect and general critical care. Now it is high time to move to specialty webinars or specialty learning. Thank you very much. With this, I would like to thank all the faculty members for sparing their time on this Friday evening and coming here and joining this side by side. I would like to thank all the delegates for sparing their time and listening to us. Thank you very much. And I would like to congratulate and thank Dr. Sharmili for this webinar. Thank you very much. Over to Dr. Sharmili, please.
Thank you so much, sir, for your kind words. And my immense thanks goes to Chairperson of ICCM Cuttack, Dr. Professor P.K. Mishra, who has been always a pillar of support for us, and Dr. Professor Rekha, Madam, the Secretary, ICCM Cuttack branch, always been very proactive and absolutely unconditional support for any academic activity with whatever length of time as a notice period. So thank you, ma'am, and thank you, sir, for being there always. And Dr. Professor Jayant Panda, Dr. M.R. Patnaik, so always been there with us as a support. And for this particularly obstetric critical care, it is Dr. P.C. Mahapatra who has been keeping us reminding at regular intervals to draw attention and discuss about these things. And I'm happy to just share with you that the continuous list coming on the chat box that we had 349 registrations, and highest viewers in this evening has been 261, which is, I think, is an amazing thing with a short notice of around 10 days. I'd like to invite our President-elect ICCM, Dr. Rajesh Mishra, for his concluding remarks.
So one of the very important subject, very close to my heart, and
concluding remark.
Sorry, Dr. Mishra was saying something.
Yeah, he's also congratulating us.
Carry on, please. Let us finish.
Yeah. So the very close, in fact, obstetric critical care is one of the area where I have been very proactive because the outcome is very good. And that really encouraged me to work a lot for obstetric sick patient. And as I told you that the outcome even in COVID obstetric patient were fairly much better than what it was for other patients. Thank you, Shamili, for bringing out this topic, and everybody of us has learned something from this. So congratulations, and over to you.
Thank you, Dr. Mishra. He's always been very proactive in matters of academics training or any kind of activities related to critical care. And
Sharmili, I have become a live member because of Rajesh. He has made me live member of this. Even if I have an obstetric,
It has been the biggest honor somebody would have given me, sir. So really thank you for that. Thank you.
Thank you.
Right. Doctor, I would like to request Dr. Professor Mishra for a few words before. Dr. Prasanna Mishra.
Yes, okay.
Father
Mishra.
Mishra.
It is very nice, Sharmili. You have really made a kind of stimulation to all of us, particularly. I'm really thankful to you also, and definitely it is unique. We have been working with Dr. Mahapatra for a long time, and I see this COVID least people were affected, but pregnant were affected. Many friends, so they remain because at home. But still, some those who are affected also, as is very nice. The only point I wanted to tell two things actually at this end, which I couldn't tell. This death after spinal anesthesia, this patient death was because probably there is a normally hypotension. There is a compensatory mechanism in a patient, but as soon as you give spinal anesthesia, in some patients they collapse. Number one. Then number two, another point I wanted to tell you, in be it COVID, be it non-COVID, in the ICU, any patient above 20 weeks of pregnancy must be lost in a lateral position. Okay, in COVID we do COVID testing, so that is what our recommendation is there. More than 20 weeks has to be no supine position because that alters the hemodynamics. So these are the two things I wanted to tell to the all participants. So thank you very much. It was very nice. Now I think over to Rekha for our thing. Thank you, Purno, and thank you everybody.
Thank you. It's a mutual appreciation ceremony. Last part.
Very important, sir. It's to keep each other encouraged, and that's the.
But remember, Sharmili, you are great. You are not only local, but national, international. I think all the faculty you have brought it, coordinated very well.
It's everyone, sir. Your blessings, best wishes, and cooperation of all my colleagues, Dr. Mishra, Dr. Govil,
absolutely,
Dr. Prasanna Mishra, and Dr. Rekha Das.
They are very dynamic.
Over to you for vote of thanks. As Secretary.
Thank you, Sharmili. You have actually done all the job. Everything is over. But we were indeed very grateful to our giant leaders within the state, like Purna sir and Jayant, for having here. At the same platform, we had such wonderful international panelists also, Dr. Hidalgo and Dr. Lopa, who is still there. She's still logged in. I must really thank her for being there for so long, and she has well highlighted about so many topics about use of ivermectin, limited use of so many useful drugs, why they should not be used in pregnancy. She has done it so well, and I must always thank our supporters, Dr. Govil and Dr. Rajesh Mishra, for their experience, sharing such wonderful experiences, and they have always been there to guide us in all the factories. Particularly Dr. Mishra, how you are planning proning in your ICU with these pregnant ladies, we must go over and see. That is very important. And that's very nice. And off-label use of cocktail also you have told. That is also something, a new thing for us. And I think we have got many audience today, a lot of viewers today, more than 200. And I am sure that many of them must have logged in primarily for their interest, because this area has been neglected. Obstetric critical care was not taken up as a subspecialty in the webinar so strongly as it has been done today. And for that, I must congratulate Dr. Sharmili for bringing us all together in one forum. And when she initiated this idea, I said, it would be very nice to have, because we have such giant people in our own state, with Professor Mahapatra and Jayanta with their experience. We must bring everyone on this platform and share our experiences. And we must also relate it to our viewers. So I must again thank everyone for being there and making this webinar a success. Thank you, Sharmili, and thank you all my seniors and my
Thank you.
Good night.
Thank you. Good night.
Thank you.
Thank
you, everyone.
Without
Good night.
thanking
Good night.
actually
Good night.
the
Very
team
nice
of
program.
Kerala team and Mr. Bharat Rajanin, especially, who has been actually constantly coordinating and supporting to facilitate this digital platform for us. So, Mr. Bharat Rajan, if you're there, a big thanks, special thanks from all of us to you, and thank you all faculties and delegates.
Thank you.
Thank you all.
Thank
you.
Thank you. Thank you, everyone. Thank you, everyone.